Uh-oh. Uh-oh. It's the camera. Turn the camera off and back on. Sorry, guys. 1 second. Our camera froze. Those of you joining us live, we'll be with you shortly. You may want to turn the ATEM completely off and back on. Unplug it and plug it back in because it's not coming through the ATEM. Ah, there we are. Nice. Ah, and we're back. Good morning. This is a Wednesday masquerading as a Monday. All right. How did you guys do last night with your homework? Any problems? I know chapter 4 is a little meaty. It's a lot of content to it. I get it. It's my least favorite chapter in the whole book, which is why I gave you the pink sheet handout. That's really the content that you need to pay attention to, is what was on that pink sheet handout, rather than trying to absorb everything that's in that chapter. Now, those of you that are going on for nursing, what you saw in chapter 4 is a very, very, very small crumb of what you're actually going to have to learn for nursing. So if you're going on for nursing, I would really pay attention to chapter 4 a whole lot more than what I gave you, because it's going to be information you're going to need. Monica. Oh, Monica, passed my test yesterday. Thank you for your amazing class. Congratulations. Good job. Monica is one of my super fans on social media, and I see all of your posts, and I thank you so, so much, and I'm super proud of you. Great job. Great job. Okay, so let me go ahead and get your scores from chapter 4. When I call your name, tell me either how many you missed or what your score was. Doodleen? Okay, do you have 1, 2, and 3 for me? Chapters 1, 2, and 3? No? Okay. Ariella? How many? None? Okay. Callie? Thank you. Carol? Thank you. Evelyn? Thank you. Courtney? Thank you. Christian?
None.
Thank you. Christian, do you have 2 and 3 for me?
Yes, I do. Number 2, I missed 2 questions for a total of 90, and number 3, I missed 9.
Thank you. Kayla? Thank you. Virgie? Thank you. Diana? Faith? Teresa? Kaylee? I got Kaylee and Kayla. Okay. Tammy? And Christina? Thank you. All right. Does anybody have any questions? Anything you missed and not sure why the right answer is the right answer? Anything I can help explain to you? Anybody? No questions? Did anyone catch the game show yesterday? Anybody? Yes? Hard?
Yes.
Okay. Did you understand once I explained the answer? Did you understand it? Okay, good. If you did not catch the game show yesterday, I would probably go back and watch the replay that's on my YouTube channel. That's we went over theory questions, so 15 theory questions, very similar to what you would see on the state exam. Okay. All right. So chapter 4 chapter 4 gives you information on body systems, right? So it breaks everything down into a body system, tells you what that body system does, different diseases that can affect that body system, all of those things. That's not what's going to be on the state exam. The state exam is not going to ask you what body system does the stomach belong to. That's not what the test is going to be. Test questions are usually presented, most of them in a scenario-based format. So you have to be aware of the changes of aging, because most of the patients that we're going to be dealing with are older population. And as we age, every body system ages with us. So remember on Monday, we learned a little bit about that fat layer that's under our skin and how that changes with age. You guys remember that? Okay, well, every body system that we have is affected by age. So instead of asking what body system does the stomach belong to, it's going to say you're working with an elderly person who doesn't eat well in the last meal of the day. What is a strategy that you can use to assist this patient? Well, if we understand that with aging comes diminished movement in the intestinal system, everything slows down, which means that they're probably still full from lunch because that hasn't moved through the system yet. Okay. It also means that the stomach itself kind of shrinks. It doesn't hold as much. You're going to see a lot of older people eat their bigger meals earlier in the day, where when we're younger, we tend to make dinner our biggest meal, right? That's where we get all the stuff, right? Well, as we age, that may not be suitable for their metabolism. And if we just stay in our own mind frame, our young body mind frame, and we're not aware of this, we may treat the patient wrong, basically. We may tell them, you have to eat your dinner. If you don't eat your dinner, you're not going. That's not based on their reality. That's based on our reality. And those are two different things. Does that make sense? Good. So we have to know the changes of aging in order to be able to care for our older patients properly. So the questions on the state exam are going to revolve around the changes of aging with each body system. But there's one in particular I want to talk about, and that is the nervous system, or especially the brain. Okay, especially the brain. Because our brain is going to age just like the rest of us. And there's going to be effects of that. And one of the effects that you see with an aging brain, particularly if a patient has dementia, this is going to be expanded tremendously with dementia, but just a regular older person without dementia is going to have effects of the brain. One of the things the brain does is makes memories. That's one of its jobs, is to make memories. Now, your brain, if you think of it like a memory making factory, that's what it does. It's a memory making factory. That factory is going to work better when it's brand new. If I want to invent something, let's say I invent this, okay, and I want to go to a factory and have it made so I can sell it, and I tour 2 factories. I go look at one that's brand new, state of the art, everything's computerized, conveyor belts everywhere, it all kind of does it on its own. It's going to give me consistent quality, and that quality is going to be pretty good because it's new. Okay. Now, if I go tour an 80-year-old factory, that factory is going to be all rusted. The gears are going to be missing teeth. It's not going to work half of the time. And when it does produce these things, they may not be of consistent quality, right? So we're still producing the same thing. This didn't change. It's what produced it that changed. Everybody with me? Well, if we think of our brain as a memory making factory, we have to understand that the brain that makes memories when it's new are going to be better quality memories, more consistent. The factory that makes memories when it's 80 years old, an 80-year-old factory, is not going to produce good quality memories. And there's going to be times where those memories just aren't going to get made. It's just offline today for whatever reason. So when we're working with older people and they say, when's lunch? And you're like, you just came back from the dining room. Yeah, you had lunch already. Why can't you remember that? Remember that you are thinking about this from a young brain. Do they have a young brain? So we don't want to say things like, don't you remember? No, they don't. If they did, they wouldn't be asking you. That's kind of a nonsense type of accusation, right? No, they don't remember. And they don't remember because the factory that had to make that memory is currently not working very well. So we're going to give them the information. I'm sorry, Henry, you just came back from lunch, but dinner is in 3 hours. But why do you think he's asking? Why would you ask when's lunch? Because he's hungry. That's right. So often we get frustrated with the question and we don't stop to look a little bit deeper. If he's asking when is lunch, chances are he did not eat lunch when he was in the dining room. So what could we do to maybe help this guy out? Yeah, ask him, are you hungry? Would you like a snack? Dinner's in 4 hours. That's a long time. You sure you don't want something now? That's okay. Grazing small bits throughout the day is often better tolerated by older individuals than 3 big meals a day because of their digestive system. Okay. So when we respond to patients, we tend to respond from our own perspective. But understand that your adult patients, your older individuals, they don't have the same experience you do. Their bladder does not work the same yours does. Their skin is not the same as yours. Their digestive system is not the same as yours. Their brain is not the same as yours. And yet we don't really think about that when we're taking care of our patients. We tend to try to shove everybody into an us-shaped box. And when you realize this, it really simplifies how you deal with your patients. It keeps you from getting frustrated with them, asking the same thing over and over and over again. Now, this situation is way exacerbated when your patient has dementia. So, just a normal run-of-the-mill older person may have short-term memory lapses. That's very common. And this actually starts a little earlier than you would think it does. Anybody in here ever walked into a room and had to stop and think, why am I here? What did I come here for? Yeah, that actually starts a little earlier than you think. Okay. Now, if you're already experiencing that, imagine what it's going to be like 50 years from now. So this is why we can have an older person that remembers the shoes they wore to a piano recital when they were 12, but has no idea whether they had lunch. Because those memories that were made when they were 12 were made with a good factory. Those memories are good quality. They're going to stick around a very long time. But when we have dementia, this can go to extremes. So with dementia, the way to think about this is your memory is not a complete memory. It's not like wrapped up in a gift wrap with a bow on top. It doesn't work like that. Your memory is actually constructed every time you think about it. And it's constructed through different impressions, sights, sounds, smells, feelings. So in here, in this room, you guys are usually cold, right? You're pretty cold all the time, I know. So 60 years from now, if you think back to this class, if something triggers a memory and you think back to this class, you're probably going to think cold. We're going to pull that impression to build this memory. You're also all in black t-shirts. So if you see a black t-shirt, you're going to pull that black t-shirt. You're going to create a memory based on these things. If you hear one of my sayings, like help isn't help if it doesn't help, you will think of this class. It'll be a memory. But that memory is going to include cold and black t-shirts and snacks and coffee and, you know, all the other things. You rebuild memories based on different inputs, different senses, and you rebuild them at the time you recall them. This is why memory is not accurate a lot of times, because every time we make it, we have to rebuild it. It's not like we can go into our memory banks and replay an actual video of the event. We have to reconstruct it. So it's not always accurate. Now, if you understand how memories are built, what happens with dementia is that the web that connects all of these little points gets destroyed. The points are there, but the web that connects them gets destroyed. Good? Makes sense? So you think of your memory as a web. This is not the only time in your life you're going to wear a black t-shirt, by the way. So that black t-shirt is going to associate with a lot of different memories. This is not the only time you're going to be cold, by the way. So cold is going to be associated with a lot of different memories. And we just use that, pull those, and create a memory that we're trying to recall. Make sense? Okay, if those strings that attach, those webs that attach, if those get destroyed, our memory gets a little bit affected by that. We're not able to recall things clearly. And the things that we are recalling may not be accurate. Now, remember that the older memories are going to stick around a lot longer. Okay? So when we have somebody with dementia and they see a person that they recognize as belonging to them, okay? So they see a female that's young and they know that person belongs to me. They may not go directly to daughter. They may go to sister, because sister might be a closer memory, one that was made earlier. They may not see granddaughter. They may pick daughter, because the daughter memory is closer, was made with a newer brain than granddaughter was. Does that make sense? This can cause a lot of frustration for families. How could grandma forget me? I am her favorite. She raised me. She loves me. How can she think that I am my mom, who hasn't been around in 25 years? Well, it's because you resemble the memory of your mom when she was your age. And that is the memory they can access with the pathways that they have left. Does that make sense? Okay. But it also can mean that they react to you in a way that you're not expecting. Because remember that older memories stick around the longest. Now, I'm just going to pick on you real quick. What's your name? Courtney. That's what I thought. Okay. So, Courtney, I'm going to pick on you for a second. So, let's say that I'm an 84-year-old woman with the beginnings of dementia. And I look at you, and you look exactly like the bully from my elementary school. You just do. Are we going to connect? No, not at all. Not at all. Because that memory, I can't recall any memories of you being nice to me. The factory that had to make those memories, not working. I've got the beginnings of dementia. I have no idea who you actually are, but you look a whole lot like somebody I don't like. So we're not going to connect. In fact, I'm probably going to be somewhat hostile. So if you're working with a dementia patient and they're a little bit hostile to you, understand it may not still self-check. We always self-check. Always self-check. Is it me? Am I rushing this patient? Am I making them feel like they're a lump of flesh rather than a real person? What is my approach? Oh, come on in. We want to self-evaluate, always self-evaluate. So when we self-evaluate and we realize, okay, I don't think it's me. I think my approach is good. I think that I'm doing the right things, those types of things. Understand that it may be a memory from your patient that is just being projected onto you. And that's okay. Who should know that? Us, but who should we tell? The nurse, because our care probably isn't going to be accepted by this person. So we need to go to the nurse and say, hey, we're just not vibing. This is not a good situation for whatever reason. She's not connecting with me. Because when you go to ask her, hey, can I give you a shower? Do you know what she's going to say? No, I'm not going to let my 5th grade bully shower me. What are you, nuts? That's not going to happen. Bye, Shannon. You're okay. That's not going to happen. So that means this patient isn't going to get the right level of care. So the person that needs to know this is the nurse. Hey, we're just not really vibing. I don't know what's happening. I did a self-check. I know that I'm approaching this the right way. And we can probably make some scheduling switches and I'll have you go in instead. Okay. Does that make sense? Remember that memories that are made early in life are the ones that stick the hardest for your patients. That kind of helps us understand a little bit more about dementia as well. Now, as dementia progresses and all of these webs degrade more and more and more, what we're left with are some points with no associations. So this especially happens with Alzheimer's. Now, Alzheimer's will degrade all of those webbings to the point that your patient will no longer be able to talk. So the end stage of dementia is your patient is unable to communicate. And a lot of times they're really unable to understand what's happening to them because they have no frame of reference left. So it's important that we kind of understand that. But we had a patient in a local nursing home who had advanced dementia, and her last word, she only had one left, was apple. Everything was apple. Apple. Now, we tried everything. We tried apple pie, applesauce, apples and caramel. We tried apple everything, and it wasn't it. I still to this day have no idea what she was trying to convey to us using the word apple. It had no association. So I have no idea, but that was the word that she had. But this woman, she only has one word, apple. She could sit down at a piano and play a song that would make you cry. It was so beautiful. So understand that even though some parts of their brain might be affected at a very, very, very high level, there may be other parts that are still intact. And a lot of what we do when we're working with dementia patients is try to sort through and find the last kernel of them. Okay. And that can help them enjoy the life that they have. Does that make sense? Good. It takes a very special person to work with dementia patients. Very special, very patient. You have to be a patient person. If you are not a patient person, please do not go into dementia care. It's not for you.
I have a question. Because we have a resident, we live together in the memory care, and then he passed away, and she keep asking, where's my husband?
Right.
Then what's the best answer?
So in this situation, she is not going to retain the information that her husband has passed away, because you're telling a factory that doesn't exist. It's not working. It's offline. So you telling that patient, I'm sorry, your husband passed away, that's going to give immediate grief. Immediate grief. She is going to grieve the passing of her husband as if she just heard it for the first time. But that memory isn't going to stick. So tomorrow, she's going to have no idea that her husband passed away. And if we tell her again, she is going to experience immediate grief. Can you imagine living the worst day of your life every day? That's cruel. It's inhumane. So a better way to handle that is not to answer, to get her involved in an activity. I'm not real sure. Why don't you come over here? Let's work on this puzzle together. Okay. Or let's take a walk while we're waiting. But putting that person in extreme grief over and over and over is, to me, somewhat sadistic. And a lot of people will do that. They call it reality orientation. It's worthless. Reality orientation only works if you have a factory that can absorb it. If we have dementia and our factory, our memory-making factory is offline, we're not going to make any new memories, then there is no sense in reality orientation because it's not going to stick. Then we move to distraction. Okay. You can also, because she's obviously grieving her husband, right? She's missing him. Now, those of you who are fortunate enough to have found your other person in life, right? Not everybody gets that. But if you are fortunate to find your other person in life, the one that you are truly supposed to be with, and you have that bond, when that person dies, half of you dies with them. And you feel that loss acutely. So we know this woman understands that part of me is missing. I am not whole. I am looking to be whole, right? Does that make sense? Okay, so what we can do, because they're missing that, is pull out a photo album. The older, the better, right? Because remember, it's the old memories that they're going to remember. The older, the better. And go through the photo album. Who is this? Where were you when this happened? Help them connect with the memories rather than the loss. Does that make sense? That's a good strategy. If it makes them sadder, then move to puzzles and walks and other distractions. But if they are asking, that means that they understand there's a loss, something is missing, and the ability to replay that may help soothe them a little bit. Every person is different. We have to approach each situation independently because what works for you may not work for you. Okay. Good? Make sense? Okay. All right. So it's important that you know, as a CNA, all of the changes of aging that could happen to your residents so that we can help accommodate those changes and not treat them like another person shaped us. How do we know what to do with each patient? The care plan. And we follow the care plan, the whole care plan, and nothing but the care plan. While we do that, we make observations. And who do we report those observations to? The nurse. Very good. Every skill starts with an opening. Every opening starts with a knock. That's right. Then we're going to greet our patient. We're going to address them by name. We're going to introduce ourselves by name and title. And then we're going to tell them what we're there to do. And the whole reason we're doing this is to be able to get consent or permission. Yeah, we want them to be a partner in care. Most people don't understand just how important this is. This is way more important than you think it is. Because 50 years ago, we didn't do this. We did not do this. When you went into a healthcare facility, we shoved you in bed, usually tied you down because we didn't want you up roaming around. We drugged you. We took away all of your rights. We did everything we wanted to you, and you had no say in it. How much do you think people actually trusted the healthcare system? They didn't go unless they were absolutely, positively dying because they didn't trust us. It wasn't that long ago, guys. It wasn't that long ago. So a lot of your older individuals, those in their 80s, they remember this. You think they're going to trust you? No. So we got to set the scene early. Like the second they lay eyes on us, we should be smiling. We should be approaching them with respect. If you don't do that, especially with your older patients, you will set up a situation where they fight against you from the very beginning because they don't trust you. So your approach is really going to matter here. And that's why getting consent is so important. Okay, good. Once we have their consent, we can close that curtain. That curtain is not clean, so we're going to go wash our hands. Our cardinal rule here, and we have to have clean hands to get our clean supplies, but our cardinal rule here is do not touch that patient for any reason until your hands are clean. That's right. That's right. We also learned when to wear gloves. If there's any possibility of touching body fluids, personal skin, or non-intact skin, then we need an extra layer of protection. If the answer to those is no, if your patient is fully clothed, holding onto all of their own body parts, you're not near anything personal, you don't need gloves for that skill. So if I'm taking a pulse on a patient and their skin is intact and so is mine, I don't need gloves. If I'm going to do range of motion and their skin is intact and so is mine, I don't need gloves. Good. But if I'm going to do mouth care on somebody, I'm going to be up in their mouth and their saliva. That's a body fluid. Do I need gloves? Yes. Understand that gloves aren't based on the patient. They're based on the skill. They're based on the patient you're doing the skill on. If you do decide to wear gloves, if you've gone through your body fluids, personal skin, non-intact skin, and there's a maybe in there, and you decide to wear gloves, the first thing those gloves should touch is the patient. Absolutely. I was watching a show on TV last weekend, one of the health shows, and they actually, I don't know, they need somebody to review this footage before it goes up like on TV, because a healthcare worker walked into a patient's room, put on a pair of gloves, and reached down and picked up dirty Kleenexes and threw them away, and then started working on the patient.
What are X's? You said the healthcare worker picked up dirty
Kleenexes.
Oh, Kleenexes.
Tissues. Yeah. That had fallen off the patient's bed onto the floor. Yeah. Ugh. Don't touch me with those gloves. Nope. So we have to understand that those gloves are not just there to protect you. In fact, that's not even their primary mission. Their primary mission is to make sure that we're not spreading additional pathogens to that patient whose immune system is already busy. Good? Good. All right. Once you have touched that patient, your gloves are contaminated. Be careful about what you're touching in your environment with those soiled gloves. And then make sure you're removing those gloves correctly. Dirty glove can touch dirty glove. Dirty glove cannot touch skin. All right. We learned how to use a barrier. Barriers provide a clean place for your clean supplies. And of course, we only touch supplies with clean hands. Keep that in mind. You also don't want clean supplies to touch your uniform because it is not clean. And then if you're going to use a barrier, if we have supplies and we're going to use a barrier, go get it first, put it on the table, and then put your supplies on the barrier. That way you don't hold it against your uniform accidentally. We learned how to use a privacy blanket. Remember, privacy blankets are not just for privacy, they're also for warmth. So even though we have a privacy curtain closed, doesn't mean that that takes care of all of our patients' needs. And that's where the privacy blanket is going to come in. We're going to use a privacy blanket anytime the patient is uncovered or undressed. Okay, uncovered or undressed. Remember, the care plan is not going to tell you, use a privacy blanket for this. It doesn't say that. These are things we have to know. So if you're going to use a barrier, that's your decision, not on the care plan. If you're going to use a privacy blanket, that's your decision, not on the care plan. Good? Make sense? Okay. When you put a privacy blanket on, we put it on over the sheet and pull the sheet down underneath so your patient is never completely exposed. Don't snap or shake the blanket when you put it on. And if you have gloves on, so if you're doing a skill that required gloves. So let me go back here. Remember, we learned how to dress the resident with a weak arm. You guys remember that? We didn't wear gloves for that because we weren't going to touch any body fluids, personal skin, or non-intact skin. We didn't need gloves. So we could just pull the sheet up. That's fine. It's patient's own cooties, right? No wet and icky stuff that holds extra cooties. Good? But we are going to learn how to do a partial bed bath next week. And for that, we are going to wear gloves because we have to wash the face. And there's eyes, nose, mouth on the face. Those are wet body openings. So for partial bed bath, still a bed skill, we're still going to use a privacy blanket when we do it. But this time we have gloves on. So if we're going to take that privacy blanket off at the end of the skill, we want to do it after we take our gloves off because your gloves have stuff from the eyes and the nose and the mouth. And we don't want that on the sheet that's going to go right up next to their face. Good? Good. All right. We learned linen rules, and most of these, the majority of these are repeats, right? We don't let linens touch our uniform. We have to have clean hands to get our linens. We don't snap or shake our linens. We learned the other one of the other two as well. Clean rolls toward me, dirty rolls away. Gotta fix that. And anything we don't use is discarded. We're gonna learn these other two a little bit more today. All right, safety first. This is scoot and roll. If you don't learn anything else in this class, this needs to be top of your list. Patients must be in the middle of the bed at all times. You cannot rely on side rails to keep your patient safe. That is your job to keep the patient safe. So if we're going to turn a patient onto their side, we're not going to use side rails for safety. We're going to scoot them toward us first and then roll them on their side so they're in the middle of the bed after the turn. Good? Good. Always turn a patient away from you. Remain behind, they're behind. We remain behind, they're behind. And patient must always be in the middle of the bed. Now, this step, this checkpoint right here, shows up on many skills, and this can fail you. One of the skills that we're going to learn is turning a patient on their side using some pillows to keep them in place and to pad all the bony areas. Okay, so that's a skill that we're going to be learning coming up. So a lot of students get hyper fixated on the turn and the pillows, but they never stop to look at the patient that's in the bed. And if you've got somebody a little on the larger side, when you scoot them towards you and you turn them on their side, they may not be in the middle of the bed. You may have to turn them back on their side, scoot them a little bit more, and then return them to the middle because they must be in the middle of the bed. It's not how pretty did you make them, it's are they safe? Good? Does that make sense? So when you're taking the test, the biggest piece of advice I can give you is quit thinking about you. Don't think about your steps, what you need to do. If you focus all of that attention on the patient, are they in the middle of the bed? Do they look comfortable? Are they in good alignment? If you can transfer that, it's all about me to it's all about them, you will automatically pass the test because that's what they're grading you on. That's the secret to passing the test, is quit thinking about you. This test has nothing to do with you. You are interchangeable. You are no different than you. You are no different than you. You're all going to go in, you're going to take care of patients, you're going to do the same skills, maybe a little bit different ways, but you're still going to do the same things, right? You're interchangeable. It's not about you. The test was never about you. The test is always about how is the patient after your care. Good? Because that's who's interchangeable or who counts here. Okay. Does that make sense? Good? Okay. All right. We learned washing rules, and we have 5 washing skills that we're going to be doing. We've learned 1 so far. So you're going to hear this a lot. When it comes to washing, basins or no soap zones, we don't put soap in the water because we have to have clean water for rinsing. We're going to use a paper towel to turn the faucet on because the faucet is dirty and your hands are clean. You've already washed them. You got your clean supplies. You're starting out with clean hands. So we're going to use a paper towel to turn the faucet on. We're going to check the water. It should feel warm, not hot, not cold, just warm. But who else needs to check that water? The patient, every time. So we ask them, how is it? Now for the test, they're probably going to say it's fine. That evaluator is probably going to put their finger in the water just to see, is it really fine? So this is not a pretend skill. You're going to use real water, and it should really be warm. All right, we're going to cover this next principle in a later lesson. Whatever we wash, we rinse. Whatever we rinse, we dry. Yep. Be careful not to get your surface wet, and change that water out if it gets cold or soapy. If you're going to put lotion on, we put it on our hands and warm it up first, and then we wipe off the excess. Let me talk to you about lotion real quick. Long time ago, we used to, in fact, when I went to school, we were trained to put the lotion bottle in the water for it to warm up, right? Warm water, lotion bottle in the water. There's 2 problems with that. First of all, I don't want anything in my water. I want my water clean. I don't know where that lotion bottle's been, who's touched it. So that's problem number 1, infection control. Not a horrible problem, but still, we can do better. But here's the real problem with that. When you have a lotion bottle, just use a small one. Okay, we have a lotion bottle. When we put this into water, it's just this outside surface that's going to be warmed up. If I squeeze this onto my skin, where it's coming from is the middle. That heat did not penetrate to the middle. So you putting this in the water is not going to make it warm, not the area of the lotion that we are using. Does that make sense? So the best way to do this, hands down, pun intended, the best way to do this is to put the lotion in your hands, rub it together to warm it up, and then put it on the patient. Now, I do want to talk to you about medicated lotion, though. Medicated lotion is designed to be absorbed through the skin. If you put that on your bare skin and rub it together, you are taking the patient's medication. So if it's medicated lotion, you must use gloves. Okay, good. I got a story about that. We used to use something called nitro paste. It's still used, but not as often as it used to be. We used to use it all the time. Now, nitro paste stuff was wicked. It came with this little patch, and the patch had little lines on it so you could dose it appropriately, right? Well, in nursing school, right, I knew nothing. Nothing. You think you know it all. You've studied, you've read the books, you've watched the videos, you think you're good. You don't know anything. So I'm in a patient's room. I'm going to be putting a nitro patch on. So I take the patch, I dose it out. I go to put it on the skin, and the patient was oily. So I put it on my hand just to hold it while I cleaned the skin. So nitro does something very, very interesting. It opens the blood vessels like that. There is no accommodation. It's just 0 to 300. And all of the blood vessels in my brain went, whoop, And all of the blood, I mean, just instant blinding headache. I was on my knees, tears coming out of my face, right? I learned pretty quick right then, if it's medicated, do not get contact with your skin. Oh yeah, that was a lesson I will never forget. It was instant and immediate.
What were you treating?
This is used, nitro paste is used when a patient has blockages. So we used to use this like way before stents and things like that were commonplace, right? Now we go in mechanically and open up arteries in the heart. We don't really do much in the brain, but we can open the carotid arteries that pushes blood to the brain. But back then, we didn't have a lot of these surgical treatments available, so we used to treat with medications. So patients with a lot of carotid artery stenosis or coronary artery stenosis, which is a buildup of plaque in those arteries, we would use nitro paste, and that just kept their arteries open so the blood could circulate through. And that's great. That is a wonderful treatment when you need it. But when you got nice open arteries, it's not so good. It is not so good. And the thing is, I didn't even get like the full dose. I just put like the edge of it on my skin. Like I didn't put like the whole paste on I just like set it on my hand, but I wasn't wearing gloves.
How long did it take for the
About 2 minutes. Your body accommodates pretty quick when you're healthy and young, you know. And back then I was really young, really young. So about 2 minutes before the dizziness cleared and I was able to see again. And I, immediately went to the nurse that was precepting me and to my instructor and explained what happened. And we used it as a learning opportunity. We absolutely had discussions about it, right? But that's part of being ethical. That's part of being ethical. Could I have hidden it so I didn't get the lecture? Sure, I could have. But that's not being ethical, is it? Own your mistakes. Because of my mistake and us having a conversation about it, I probably kept other people that were in my nursing cohort from doing the same thing. Own your mistakes. Part of being ethical. All right, so we're going to warm up the lotion in our hands, put it on, and then wipe it off. All basins are cleaned the same way. For the test, rinse it, dry it, store it. For the test, rinse it, dry it, store it. But there is a process that I'm showing you that allows for disinfection as part of the overall process. So if you dump it, rinse it, dump it, set it down, and then pick it up with a paper towel, between setting it down and picking it up, you can disinfect. Now, when you pick it up with a paper towel, you're not cross-contaminating. Dry the inside with a paper towel, dry the outside with a paper towel, and then one more for the drawer. Good? Okay, so we dump it, we rinse it, we dump it, we set it down, we spray it if you need to, pick it up with a paper towel, dry the inside with a paper towel, dry the outside with a paper towel, and then grab one more for the drawer. Throw those paper towels away, you're done with them. All right, we also learned the closing. Wow, look how much we've learned. So we've also learned the closing. Closing is pretty long. There's a lot of steps to the closing. And the best thing to do is to get your own little rhythm and routine and do it the same way every time so you never forget anything. That's really the best way to do this. Just make your own routine. Mine sounds something like this. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Environment is clean. Bed is in the low position. Are you comfortable? Is there anything else I can get for you while I'm here? Would you like a magazine before I go? Preferences. You're covered. You don't have to say that, but you do have to look. Should I ever see knobby knees? Nope. Don't let me see those knobby knees. And then you're going to open the privacy curtain. Give them their call light as well. It doesn't matter what order you do all of those things in. However you want to do them is fine. An easy way is comfort curtain, call light, clean. That's kind of an easy mnemonic. It all kind of flows together. Comfort, curtain, call, light, clean. But make it yours. Doesn't matter how you do those things, but they all have to be done. Once you've done all that, then you're going to go wash your hands. If documentation is required, remember, everybody gets a documentation skill. During your test, you are going to have to document something for one skill. So if documentation is required, we wash our hands, then we document, then we wash our hands again, because we must end skill with clean hands. Good? Good. All right. Now, we've also learned some skills. I'm going to go through these really, really quickly because we have a lot to learn today as well. We learned how to wash our hands. When you're washing your hands, you're going to wet them, put soap on. You're going to scrub a dub, all areas for at least 20 seconds. You're going to rinse, not touching the sink. You're going to tap to keep the water in the sink. You're going to dry what's clean, throw that away, get a clean paper towel, and turn the faucet off. We learned how to take a pulse. We don't use our thumb for a pulse. We use 2 fingers. It's at the top of the thumb side of the wrist. Your thumb should be on the back for consistent pressure. Normal is between 60 and 100. You're going to count as long as the care plan tells you to. Now, I'm going to stop here for a second because I want to be very, very clear with pulse. The last game show that I did a month ago, because the one 2 weeks ago didn't work, a month ago, the last game show that I did, I had this question. How long do you count a pulse? Now, the right answer was as long as care plan tells you to. That was the right answer. But I had 1 full minute. I had 15 seconds and multiply by 4. And I had until you get the number 60. A lot of people picked until you get the number 60. We are not just counting. We are counting what we feel. If you're just standing there going 1, 2, 3, 4, 5, 6, you're not counting anything. That is kindergarten work. That's not CNA work. What we want to do is find the pulse, and we're going to count what we feel. All of those thumps under our finger. 1, 2, 3, right? We're counting the thumps that we feel. So we're not just standing there and counting until 60. Okay? So I want to be very, very clear on that. That one surprised me. I kind of figured that was a throwaway answer. That was like a, I can't say what I didn't think anybody was going to pick that answer, okay? And it really surprised me how many people chose that. So I want to be very clear on that. Dressing a resident with a weak arm. USA first. Undress strong arm first, and then dress the weak arm first. Make sure that when you're putting clothes on, they're all lining up properly. Don't overextend or force movement. Make sure you're protecting privacy. There's really not much to this. As long as you remember, undress strong arm first, dress weak arm first. Range of motion. CNAs do exercises to retain function. And I had this question yesterday. Why do CNAs do range of motion exercises? And a lot of people put to heal contractures. That was the number one answer. To heal contractures. Are we healing anything? Nope, not our job. We don't do things to make things better. We're just trying to keep them from going downhill while we're doing everything else for the patient and they're not moving a whole lot. Good? Good. Flexion extension is up, down. Abduction, adduction is side to side, and rotation is around. Remember those movements. Flexion extension is up, down. Abduction, adduction is side to side, and rotation is around. We just follow the care plan. It tells us what body parts. It tells us what exercises. It tells us how many times to do them. We follow that care plan. That's all we do. Hand and nail care. We're going to follow the care plan. You guys tired of hearing me say that yet? We're going to follow the care plan. If the care plan says to do one hand, how many are we doing? One. Why? Care plan. Absolutely. Hey, Julie. We're going to soak the hand in the basin. We're going to take it out and put it on a towel to wash. We're going to put it back in the basin to rinse. We're going to take it out and put it on a towel to dry. We're going to clean under the nails with an emery board, wiping it off in between. We're going to file with a nail file in one direction only, not back and forth rapidly. We're going to warm the lotion up, put it on, and wipe off the excess. You learn how to make an occupied bed. Clean rolls toward you, dirty rolls away. This is how we do anything that's under the patient. If it's a chucks, it's still clean rolls towards you, dirty rolls away. If it's a draw sheet, it's still clean rolls towards you, dirty rolls away. Doesn't matter what it is that we're putting under the patient, this is how it's done. Good? So we're going to change that bottom sheet a half at a time. I'm going to work on this half of the bed, and then I'll go over and work on that half of the bed. And by the time I'm done, they'll be on a clean sheet. Make sure your patient is always in the middle of the bed as you do that skill. Put the top sheet on, secure the bottom of the sheet so it's underneath the mattress, and loosen it over the toes. Then change the pillowcase. This is not a hard skill. It is a physical skill. This will give you a workout. This will absolutely give you a workout. Anybody have children? If you have children, throw them in bed. They get the biggest kick out of this. Yeah. If you have kids, throw them in bed. Tell them you're going to make the bed around them, and they will just giggle the whole time. Look how much you've learned. It took us an hour to go through what you've already learned in this class. You guys are way more prepared for the test than you think you are. Okay, good. All right, we are down to one final principle to learn. That's it. Remember day one? That was only 2 weeks ago, like a week and a half ago, actually. A week and a half ago. Do you guys remember day one? Like hour one? I told you you're going to have to learn everything on that back wall, and your eyes got like this big. You guys remember that? Yeah, well, you've already learned it. Hard part's behind you. We have one more to learn. I'm going to make that really easy too. Easy. We do have the testing care plan sets. Oh, Jake, don't forget to give them their testing.
Yes.
We do have testing care plan sets that are available to you. If you buy the practice kit, which I think I've got some on the shelf over there, the practice kit actually comes with these little care plan cards in them, which has the care plans. All of this is in your book on page 25, though. You have it. The care plan sets just have the checklist on the back. That's what makes them a little bit different. All right, so are we ready to get started on a new skill? We're going to go to page 138. If you look on page 138 of this book, your spiral book, down the side, you'll see all of the principles that are involved in this skill. They're all spelled out for us here. If we follow this, along with our skill-specific steps that we're going to learn, we will get 100%. Short version of the skill is here. And I said short version. Look how many steps are there. And I said that's the short version. Down here is your skills or test specific information. Somebody with your level of experience should be able to do this in 8 minutes or less. We're going to take a look at that care plan, but just remember we have 8 minutes to do it. I'm going to talk a little bit more about that in a minute. It's going to be a live testing student. That means that one of you guys might find yourself in the bed during this skill. Patient will start out in the bed. This is not a charting skill, so no documentation is required for this one. Step-by-step instructions are located on page 139. So it tells you step-by-step exactly how to do this skill. Now, we just talked about that testing care plan set, right? And I told you the biggest difference, you've got this part on page 25. The biggest difference are these, the checklists that you're going to be using. Good. If you look at the step-by-step instructions, let's just look at number 15 here. Okay, let's look at 15. Do you see at the end of 15, it's got a little number in a bracket? It says 9. You guys see that? What that is if this is the checklist for this skill, this is the checklist. So if I went to 9, this is the checklist that this step is going to check off. So I've already done the cross-referencing for you. But when you're looking through all of the skills, you'll see these little, in the brackets, these little numbers at the end. And what those are is a cross-reference to the actual checklist you're being checked off on. Good? Good. All right, supplies are at the bottom of the skill. Care plan's at the top of the skill. Let's take a look at the care plan together. It says, position the resident on his left side. What side? Can I put him on the right?
No.
What if they ask to go on the right? No. We're going to put him on the left. Who should we tell, though? The nurse. That's an observation. Yeah. We want to know why. Why? Whoa. You're supposed to be on your left right now. Why do you want to be on your right? What's going on? Why? There's a story there. Patients don't just say that because there's a story. Is their right side sore for some reason? Are they uncomfortable? What's going on? Right? There's a story. Good? Make sense? The nurse is the one that needs to know the story. All right. So it says, position the resident on his left side. Patient requires support to remain on his side and is unable to assist with turning. So we're doing all the work here. Do you guys remember on Monday, I told you that if you turn a patient onto their side, gravity will pull them back onto their back? You guys remember that? This is why we always roll them away from us. Okay. So it tells us here that the patient can't stay on there. You can stay on. Anybody like lay on your side ever? You stay on your side, no problem. Why can't our patients stay on their side? Well, because it requires muscle action to stay on your side. Gravity does try to pull you back. It does. But your body is able to accommodate that. This patient isn't. Good? Make sense? All right. So we're going to use some pillows to keep them there on their side so that they don't accidentally roll onto their back. Says they're unable to assist with turning. That means we're going to do all the work. But I want to ask you a question. Now, do you remember me talking about the care plan, the whole care plan, and nothing but the care plan, right? Your brain is going to trick you. This says unable to assist with turning. Does it say that they're immobile? Does it say that they're paralyzed? It says they're unable to assist with turning. Yeah, if I didn't point that out to you, all of you guys would make this person immobile. So how does this happen, right? I'll give you an example. This can happen a million different ways. Let me give you one that so you can kind of put it in your memory banks. Let's say that this patient right here had open abdominal surgery. We cut her from here to here. 2 parts of her abdomen are no longer talking. We stitched them together, but they aren't working together. Okay, it's a group project and neither one of them are on board. This patient is not going to be able to roll onto their side because they need their abdomen to work together to make that happen. I did not say that they had a stroke and are paralyzed. I said that they can't roll on their side, which is why they need us. Those are 2 totally different things. If this patient is completely paralyzed, that is a different thing than just unable to roll. Got it? Your patients are going to come in all different flavors, all different levels of ability. Do not assume worst case scenario. And this is why I say care plan, whole care plan, and nothing but the care plan. Because your brain will put all kinds of things in here that don't belong. Good? Or we already know all these principles. We just reviewed them. I'm not going to review them again. So let's get into the skill-specific steps for this particular skill. So we have just a few things to learn to make this skill possible. But before we get there, I do want to talk a little bit about immobility. Understanding it's not this patient, but it does bear talking about how do we deal with immobile patients. Well, this term, immobile, tells us what we need to know. It means the patient cannot move on their own. If somebody can't move, are they going to be able to brush their own teeth? Are they going to be able to feed themselves? Are they going to get out of bed and go to the bathroom? If somebody is immobile, they can't do anything for themselves. We call this total care. Total care. They have to rely on us for absolutely everything. We are bathing them. We are taking care of their toileting. We are feeding them. We are doing mouth care on them. We are doing hand and nail care and foot care on them. We are turning them. We are doing everything for this patient. You are not going to have a ton of immobile patients. Most of your patients will be able to do something for themselves. But for some reason, in school, our minds kind of go to this, right? This is worst case scenario, but we're always on worst case scenario team. Understand that most of your patients will not be like this. Most people will be able to do something on their own. And that's why we need the care plan, because everybody's level of ability is going to be a little bit different. They'll be able to do something on their own, but that something might be different for each person. Good? Make sense? This is why care has to be individualized. But there are some really real world problems with being immobile. Real world problems. In fact, being immobile affects every body system. Remember all those body systems we learned about in chapter 4? Yeah, it's going to slow digestion. Stuff doesn't go through the circuit or the digestive system very well. And that's because, this is interesting, when you eat, that food goes into your stomach. Your stomach moves on its own. Your stomach will rumble on its own. It's pretty self-sufficient. But it moves from the stomach into the small intestines. Now, the small intestines don't move on their own. They're kind of lazy. Food just kind of floats through the small intestine. And the way that it gets, and your small intestine is like feet long, right? So the way that food moves through your small intestines is actually because of your abdominal muscles. As you sit up, as you lay down, as you turn, as you breathe, when you walk, all of those actions make your abdominal muscles move. And if you spend just maybe an hour sometime in your life paying attention to this right here and how much it moves, you'll start to see that a lot of the things that we do that we don't really even think about actually moves these muscles. And that in turn moves food through your digestive system. This is why you're told to take a 15-minute walk after you eat. Move stuff through your digestive system. So if we have somebody that's immobile that isn't moving on their own, how much work is their abdomen doing? None. So that food just kind of gets to the small intestines and it kind of stops. And then it turns to cement. And this constipates the patient and can lead to things like fecal impactions that are very, very painful for our patient. So we need to understand that if we have a patient who is truly immobile, this is going to play a really big part in their care, digestion. And a lot of people don't think about that. It's also going to reduce lung volume. Your diaphragm at the base of your lungs has to pull down That creates a vacuum. You breathe in, and it pushes up, which pushes the air out. Well, if you're laying down, that diaphragm doesn't have much room to work. So it only draws in a little breath and it only exhales a little breath. Well, that means the stuff in the bottom of your lungs isn't getting moved around very well, and it tends to get hard and crusty. You ever have a cold and wake up and your nose is kind of crusty? Yeah, that's what happens in the bottom of the lungs when your patient is immobile, but it's inside the lungs. So it's really hard to get hard and crusty out of the lungs, right? So this becomes a problem. It actually sets our patients up for things like pneumonia. Decreased bone density. Now, this one is surprising. This one is very surprising because if you don't use your bone, you lose your bone. And when we have somebody who is trapped in bed, immobile, and is non-weight bearing, their bones will actually start to break down. So if they do get better, for whatever reason, they do improve, their mobility may be affected for the rest of their lives. And I always get a kick out of this. If you ever watch any movies, somebody that's been in a coma for 20 years, and then they stand up. Yeah, that doesn't happen. Not in real life. Your bones are very, very porous. Your muscles have decreased in strength and function because of atrophy. You are not in a coma for 20 years and then just stand up. Yeah, like Independence Day 2 was really bad for that. Right? I'm yelling at the TV. My husband hates that. All right. Muscle atrophy, we just talked about. Decreased immune response. Your immune system is affected when you are immobile because a lot of our immune system lives in our gut. And what did we find out about our gut? It's affected. So, man, we have got a lot of problems here with being immune or being immobile. And then we've got this one, cognitive function. Your brain relies on sugar. In fact, your brain only eats sugar. That's what it runs on, is sugar. Well, when we have somebody who's immobile, they're not eating a whole lot of sugar. They're probably on a very, very calorie controlled diet. But your brain also relies on blood to bring that sugar to the brain. And because we're laying down, the heart isn't pumping very hard, which means that the blood going to the brain is just kind of meandering. Right? It's not like whoosh, whoosh, because we're active. It's just like, right? So the blood is just kind of trickling, which can affect your ability to think. So you put all of this together, and we didn't even talk about the skin yet. You put all of this together, and this looks pretty bleak. We don't like to put people in bed and leave them there because there's a whole lot of problems that are going to go on with this. So even patients that are immobile are often getting out of bed. We use lifts like Hoyer lifts or mechanical lifts, which is a sling we put under them. We attach it to this bar that lifts them to a sitting position, swings them around, and puts them in a wheelchair or a bedside chair. We get them out of bed. A lot of times we'll get them out of bed onto a shower stretcher and take them to the shower room to get showered. But putting somebody in bed and just leaving them there for the rest of their lives will make sure that that life is very, very short. Good? Make sense? But this is the biggest effect that we can see, and that's with the skin. So for the next 2 minutes, I want you to play along. I want you to take one hand and put it underneath your leg while I talk. So I'll tell you when to pull it out. You will want to pull it out earlier. Please don't. Please play along because I'm going to show you something that's really, really amazing. Okay? So just play along with me for a minute. Our body has pressure points. These are areas where the bone is close to the surface and it presses down because of gravity. So this patient laying here, gravity is pulling her down. Where the bones push down on the muscle, those are pressure points. The back of the head, the shoulders, the backs of the elbows, the hips or coccyx area, backs of the thighs, backs of the calves, and the heels. These are our main pressure points. There's a whole lot more, but these are the main pressure points that we want to pay attention to. And if your patient is immobile, you need to know this because you need to know where you're looking for changes. Okay. Now, what happens here is we have a bone that's pressing down on muscle, that presses into the fat, that presses into the skin, and what's in the skin are blood vessels. So this weight, and it's your whole body weight, by the way, this weight presses down, and the bottom of the pile are blood vessels. So all of that weight presses on the blood vessels, and they do this. And now they're closed. That means that this area isn't getting fresh blood. What do you think happens to skin when it doesn't get fresh blood? It dies. Yeah, absolutely. Those cells need fresh blood. So we've put pressure, 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 closed it off, and now it's not getting fresh blood, and it can die. Now, it's even worse if underneath you've got something with wrinkles, because these are going to press up. The bone is pressing down, and the skin in between is trapped, and now we've got twice as much pressure in that area. You guys are uncomfortable now, aren't you? You want to pull that hand out, don't you? Don't do it yet. Almost there. So we need to understand that this pressure from above and this pressure from below can actually close off these blood vessels. And if we leave it there long enough, that skin will actually start to separate. And that is called a pressure sore. Go ahead and take your hand out. Now I want you to look at it. Look closely. Do you have color changes? Can you see, if you look really, really closely, can you see the imprint of your clothing or the chair embedded in your skin? That was 2 minutes, guys, and your skin is healthy. That was 2 minutes, and you were uncomfortable. You wanted to pull your hand out. Now, imagine for a second, we have an immobile patient that is stuck in the same position for hours and hours and hours and hours, and they can't change their position. How frustrating do you think that would become? How painful do you think that would become? Now, if you have lines in 2 minutes and you are healthy, you have lines in 2 minutes, how deep do you think those lines are going to get in somebody who is not healthy and left in that same position for hours? Bed sores can occur. They can develop in as little as 2 hours, completely cut through the skin, in as little as 2 hours if the conditions are right. That's crazy. Crazy. You do this automatically without even thinking about it. Not a single one of you came in this room, sat down, and you're in the exact same position you were when you sat down an hour and 20 minutes ago. You move. You jiggle your leg, you shift your weight, you move to the side, you put your hand on your head like this. You cross your legs, you uncross your legs, you shift. You are constantly moving. You don't realize it, but you are constantly moving. The reason you're constantly moving is this. This is why you're fidgety. Because your muscles are saying, hey, we need some blood. Your nerves say, let's move. Let's relieve the pressure over here and put it over here. A few minutes later, these muscles say, hey, we need some blood. And the nerves say, okay, let's shift to here. A few minutes later, the muscles say, hey, we need some blood. And the nerves say, let's shift to here. This is why you get fidgety. Well, it's natural. It's normal. This even happens when you're sleeping. You do not stay in the same position all night. Your body moves because of this. Now, if we don't do this on ourselves, if we're immobile and we can't shift our own position, that means that somebody else has to do it for us. Good? This is a very big part of caring for immobile patients. The most important part. Yes, we're dealing with digestive issues. Yes, we're dealing with lung issues. Yes, we're dealing with bone density issues. Yes, we're dealing with immune issues. But this will kill your patient quicker than anything else. Way quicker than anything else. Because these bed sores, when they form, they go deep. They go to the bone. And any skin opening is a doorway in. What is this patient at risk for? Infection. And that infection will go straight to the bloodstream and kill your patient. This is the biggest risk. So when we have a patient who is immobile, we are going to turn them every 2 hours around the clock. We're waking them up at 2 a.m. We are waking them up at 4 a.m. We are waking them up at 6 a.m. And a lot of very well-meaning CNAs that don't understand the care plan, but they're well-meaning CNAs, they think to themselves, oh, I really don't want to wake up Mr. Roberts tonight. He hasn't had a good night's sleep for ages. I'm going to let him sleep all night. I'm not going to go in and change his position. We're just going to let him sleep. Now, that sounds very decent on the surface, doesn't it? It sounds like we care about Mr. Roberts. But when we wake him up 8 hours later, do you know what he's going to have? A huge bed sore, and he is not going to sleep for the rest of his life, which won't be very long. So you were well-meaning, but what did you end up doing? You killed him. That's right. Do you remember me saying on day one that CNAs kill just as many patients as surgeons every year? And I think we should be talking about it. This is what happens when you do not follow the care plan. There's a very real-world consequence on your patient that you made for them. And that real-world consequence is likely to kill them. This is why we do not deviate from the care plan. Ever. Because there's so much of this that you don't know. Good? Make sense? Okay, so we're going to move this patient every 2 hours around the clock. And the way we do this is usually we start on the back, 2 hours later, right side, 2 hours later, back on their back, 2 hours later, left side, 2 hours later, back on their back, right, back, left, back, right, back, left, back, never on their stomach. If that care plan does not specifically tell you to put the patient prone, which means on their stomach, we do not put patients on their stomach because remember, one of the things that's affected with immobility is muscles, right? So if we have somebody laying on their stomach, they have their entire body weight on their lungs. And if their muscles can't inflate, can't move enough for those lungs to inflate, you will suffocate your patient. You put them on their stomach, they died. What happened? You happened. You did not follow the care plan. Okay? So this is called a turning clock, and CNAs can make this. You are allowed to make this. You are encouraged to make this. And all it is just a simple clock, and we color in. So this is the AM clock. This is the PM clock. So at 1 a.m., this patient should be on their left side. So if I'm the nurse and I walk in the room and I see a turning clock on the wall, patient is immobile, I can look at it at 1 a.m. Patient should be on the left side. I should look at the patient. They're on the left side. Good. My CNA is doing their job. This keeps everybody on the same page. Now, if I come in at 10 till 2 and I say, okay, the patient should be on their back at 2 and I'm already in there, I'll probably just go ahead and put them on their back for you, right? I can help because I know where we are in the turning schedule now. So CNAs are allowed and encouraged to make a turning clock to put on the wall. But this also keeps us honest, right? We don't have to remember where is the patient going next. It also tells the family, hey, look, we are taking care of this patient. Here it is. They're on their back. We're doing the right thing. Yes.
Because I remember I was thrown off. They were like, "We have to take a photo of your foot," and I was like, "Why?"
So we do that with wounds, especially if there's a wound, if there's an infection, because me saying that the infection is improving, that doesn't really mean anything. But if I have a photo that can show that a wound went from red and angry and irritated and icky and drainage everywhere to light pink, the edges are approximate, that type of thing, a picture really is worth 1,000 words rather than just saying it's improving.
So that's like if someone comes in with it already, and someone's like a liability type of thing, like someone can be like, oh, you did this to me.
Yeah. Yeah, part of that is liability management. Sure, absolutely. So I hate to say this, but it has to be said. Okay. We now know how important turning a patient is that's immobile, right? Right. If it's not on the care plan, if you're dealing with an immobile patient, they can't move because you're assigned to do everything for them and there's nothing on the care plan about turning them, should you ignore that? What should you do? Tell the nurse. That's right. Because maybe the nurse got distracted or maybe the nurse just didn't think about it. Right? Because we're human. We have a lot to go through. Oh my gosh, the assessment on this patient takes hours. And I got to write all that down. And I'm getting interrupted by family, by CNAs, by doctors, by the phones ringing. Do you think that there might be a possibility I forget a thing or two? Right? I'm not a machine. So go to the nurse and say, hey, this patient's immobile. Am I supposed to be turning them every 2 hours because it's not on the care plan? And the nurse is probably going to go, thank you. Yes, turn them every 2 hours. Let me know if you see any skin changes. I want to know right away. Is there any changes, red areas, things that look like bruising, abrasions, anything? If it's whiter than normal, let me know because whiter means no blood flow. Okay, so any changes, let me know about them. That's important, right? So, and thank you for saving. And you should go to nursing school. Okay, so they're going to be thankful for that. But the most common place for bed sores to occur is in the hospital. It's the most common. We think it's nursing homes. We think nursing homes are responsible for bed sores. No, nursing homes have got this down. They figured this out a long time ago, and their patients get turned. They get turned because the nursing homes get fined if the patient develops a bed sore. It's all on us. And when I say fined, I mean big fines. So nursing homes have got this down. But in a hospital, you're not there because you're immobile. You're there because something else went horribly wrong. Either you got pneumonia because your, stuff got all hard in your lungs, or you're there because you're impacted and now we have to do surgery because your digestion wasn't working real well. You're there for something else. And we're paying attention to that something else. We're not paying attention to the fact that you're immobile, which means we're probably going to leave you in the same position for hours and hours and hours and hours. And what's going to happen? A bed sore. So the number one place that bed sores actually occur is in the hospital because we don't pay attention to that aspect of this patient's care. We're more focused on what's immediately wrong with them. Now that's got to change. And it is a mission of mine to make sure that changes. So if you find yourself working in a hospital and you know the patient is immobile, make sure that we are changing their position every 2 hours because there is a whole lot of patients that go to the hospital for heart attacks, for strokes, for diabetic issues, and they come back with a bed sore. Now, all we've done is complicate the whole situation. And it could have been solved if somebody had just turned them every 2 hours around the clock. Good. We need you to be our eyes and ears too. Okay. Questions on that? All right.
If you're not assigned to the patient, but you see they should be turned, should you go ahead and tell the nurse or turn them yourself?
No, we don't do anything on our own. We never do anything on our own. Because you don't know as a CNA what's actually happening with that patient, okay? So let's say you're a CNA, you know the patient's immobile, Nothing on the care plan. So you just decide to turn them, and you turn them on their right side. And what you didn't know is they had a hip replacement very, very recently, and their hip actually slips out of joint because you turned them on that side. Okay. There's always something about that patient that you just don't know. So never do anything on your own. Go to the nurse and ask, hey, there's nothing on the care plan about turning them, and they're immobile. We don't want bed sores. Do you want to add that to the care plan? Is there a side that I cannot turn them on? Okay, good. Okay. What, more or less, what do you object to on that?
The patient is not assigned to you, but you notice they have not been turned.
Okay, if the patient is not assigned to you, okay, if you have no authority over that patient at all, then no, you don't do anything, because you don't know anything about that patient, what's on their care plan, how they should be cared for. You don't care for any patient that has not been assigned to you. Remember on day one, we talked about our scope of practice, right? We follow the care plan, the whole care plan, and nothing but the care plan, right? That is the basis of our scope of practice. Well, if you go in and you work on a stranger that hasn't been assigned to you and you don't know their care plan, you're not following their care plan, which makes you liable.
Okay. So then in that case, we just tell the nurse that they haven't been turned and leave it to the person assigned to them?
Yeah, absolutely. Absolutely. Just let the nurse know, hey, I'm dealing with the roommate, but I've noticed that patient hasn't been turned in like 3 hours. You can bring it to their attention. Yes. Yeah. We want to take good care of our patients. We do. But we also don't want to be accusatory. We don't want to cause a lot of hostility within the nursing workforce either. And the fact is that if you don't see a patient being turned, that doesn't mean that they're not being turned, or it doesn't mean that they need to be turned. Okay. They may be on an alternating pressure mattress, which is a special mattress that literally the air pockets decrease and increase, and that actually moves them. Okay. So again, without being assigned to the patient, you have no idea what their level of ability is, what's required for them, and what's currently being done for them. Okay. Does that make sense?
Yes, it does.
Okay. So again, stay in your lane. Make sure that you're working as well as you can with your patients, the ones you're assigned to. If you have concerns about others, you can relay that to the nurse. But don't go looking for problems that aren't in your lane. Okay. Because that CNA will probably get upset with you. And then you have to have their help later to turn a patient, So yes, we do want to take good care of our patients. Absolutely. And if you have a legitimate concern about the well-being of the patient, bring it to the nurse's attention. But try to do it in a way that's very tactful and that is not accusatory. I know that patient isn't moving on their own. Are they being, do you want me to go change their position? Or is that being taken care of? That would be a much more tactful way of saying it, rather than that patient's not getting turned and I'm going to do it for you. Okay. Does that make sense?
Yes, ma'am.
Okay. So we always make sure our patient is in the middle of the bed, always in the middle of the bed, but especially when they're being turned on their side. How do you think this patient feels? Oh, yeah. Yeah, they're really, really concerned at the moment. So we're always going to scoot them toward us and then roll them away from us, so that after the roll, they're in the middle of the bed. And like I said, with larger people, you may actually have to do this twice. You scoot them towards you, you roll them, they're not in the middle. They're still way too close to the edge. Bring them back on their back, scoot them a little more and roll them. They have to be in the middle after the roll. This is the important part. After the roll, they're in the middle of the bed. Good? All right, for the test, let's go back to our care plan. Our care plan says that they're unable to assist with turning. You guys remember that? Unable to assist with turning. But we can ask him, hey, can you scoot toward me? Scooting is not turning. So can you scoot toward me? Cool. For the test, they'll be able to. That's easy. If they can't, you move them in segments or you use a draw sheet. We talked about that last class. Now, when we set somebody up to turn them, if I just grab this patient, okay, if I scoot them toward me and I grab this patient and I put a hand on the shoulder and one on the hips, I'm going to have to really handle them to get them on their side. It's going to put a lot of pressure on my back and on them. I'm going to have to push super hard. They're probably going to get injured, or I am. That's not a good situation. What we want to do is prep the patient for the turn. When you do the prep work, the turn, you can almost do with 2 fingers. I don't care how big the patient is. It becomes super easy to get them up on their side as long as you prep them properly. And the way that you prep them is first you have to know which side you're turning them on. That's the first step. This care plan told us to turn the patient on their left side. So I am turning this patient to the left, okay? So you have to know which side you're going to turn them on first. The next step is to take the furthest arm, okay? So if I'm going to turn somebody on their left side, I have to remain behind their behind. So that means I am on the right side of the bed. Got it? To turn them on their left. So I scoot them toward me. And I'm going to take their furthest arm, which is this one, and put it over their head. The closest arm, which is this one, because remember, I'm standing here, closest arm crosses their chest. So they look like this. Now, if I were going to turn them on their right side, I would have them scoot toward me because I'd be standing over here. And the furthest arm goes up and the closest arm crosses the chest. Good? But this care plan tells us to turn the patient on their left side. So I'm going to have them scoot toward me. I'm over here, furthest arm up, closest arm crosses. Good so far? We're halfway there. Now I'm going to take the closest knee to me. I'm going to bend the knee and put the foot flat on the bed. I'm going to take the furthest knee and angle it out. So bent, angled out. Now when I have a patient in this position, furthest arm up, closest arm crosses, closest knee bent, furthest knee angled. When I get them in this position, I just take a hand on their shoulder, one on their hip, and just boop, roll them on their side. Super easy. Okay? No stress on them, no stress on me. Now, early in my career, I worked with morbidly obese patients before they went in for stomach surgery. These are people that are 500, 600, 700 pounds that can't get out of bed. They are truly bedbound because their bones just won't support their weight. So we had to turn them quite often. Now they're in home. They're at their home. This is home care. I go into their home alone. There's nobody to call. There's no staff member to help me. I have to do this by myself. 500, 600 pound patients. Get them to scoot towards you, and they usually can. Furthest arm up, closest arm cross, closest knee bent, furthest knee angled, and you can turn somebody that weight by yourself using this technique. Good? All right. Make sure the patient is in the middle of the bed. So when you get them rolled, you should take a step back and look. Are they in the middle of the bed? Because I guarantee you that evaluator is looking to see, are they in the middle of the bed? It's not how pretty you made the roll. I don't care about that. I care about, are they safe? Got it? Okay, once we have them on their side in the middle of the bed, we got to do some things to keep them there. And one of the things that we're going to do is put a pillow behind their back. And we want this pillow to be in a roll. So what I'm going to do is take a pillow. So if I have this, you can't do this on a mannequin. They'll fall right off the bed. Trust me. Okay, so if I scoot the patient toward me, furthest arm up, closest arm crosses, furthest knee angle, closest knee bent, and I've got them laying on their side in the middle of the bed, I'm going to put this pillow up against their back kind of like this. So it's kind of at a slope, ski slope. And I want this part to be right around, like right about here, like almost to the top of their side. Okay. And I need it that high because I want to tuck this underneath the patient where it's at. So I don't want it tucked just a little bit. If I have it like this, I'm barely going to tuck it under them. When I put it like this, I'm going to push this down and under the patient. I want their whole body to be laying on it like this. I want their whole body to hold this in place. Because if their body doesn't hold it in place, it's going to come flipping out and the patient's going to be back on their back. Once I have this edge underneath the body as far as I can get it, I'm going to roll this edge up and I'm going to tuck it down and under. Now, when I do that, see this roll? This is what's going to keep my patient on their side. Good? Good? All right. Once I have my patient on their side, and I've got the pillow there to hold them in that position so they don't come back onto their back, now I'm going to go around to the other side of the bed and I'm going to put one in between their legs. I don't want the legs laying right on top of each other. That's too much weight on that bottom leg. So I'm going to move that top leg just slightly off center a little bit. Just shift it forward a little bit. That way, I don't want it like totally, I want it just a little bit. That way it's not putting all of that pressure on that bottom leg. And then I'm going to lift that top leg and I'm going to put a pillow in between those two legs. That keeps the hip in a neutral position, but it also keeps the knees and the ankles from rubbing together. We don't want knees or ankles to rub together. Remember that pressure we talked about? Okay. So pillow behind the back. We're going to put one between the legs, making sure that the legs are offset a little bit. And then we're going to put one underneath that top arm. This is the one that a lot of people miss, this pillow. A lot of people miss this. We know this one because patient has to stay on their back. We know this one because we want those legs separated. But this one, a lot of people don't think about. When a patient is on their side, this top arm laying against the body is actually going to pull forward because of gravity. It pulls forward. And this puts a lot of pressure along the neck and the shoulder. And it can cause muscle spasms or headaches. It causes a lot of tension and it's just uncomfortable. When we put a pillow underneath that elbow, on that top arm, just underneath the elbow, that relieves all of that tension and it can help prevent a lot of complications with the patient. Okay, just make sure that that pillow is under the elbow and it's not over the face. And then we look at the pillow that's already on the bed. Okay, we want to make sure the arm is not hanging off the bed at all, that bottom arm. But I want to look at the pillow because if it's underneath that shoulder, if we turn the patient onto the pillow and it's under that shoulder, it's going to scrunch up that neck. Again, headaches, muscle spasms, bad things. So I want to lift the head up, adjust that pillow a little bit so it's just under the head and the neck, not that shoulder. And I'm going to tuck that bottom arm under the pillow so it's not hanging off the bed where somebody can hurt it. This actually happened. This was a lawsuit. A patient was turned onto their side and their arm was hanging off the bed. Just kind of hanging there. So like the bed ends here and their arm is just kind of hanging off the bed. We don't think anything of it because you probably sleep like that occasionally, it's fine. The problem is that when your patient is immobile and they can't move on their own, or if they're deeply asleep and unable to acknowledge the danger of the area, when their arm is off of the bed, there's not a lot of rooms, not a lot of room in a hospital room, like between two beds, not much room there. So let's say that RT, respiratory therapy, comes in with a big old vent. Okay, wheeling in a big piece of equipment. They're on the other side of the equipment. They can't see in front of it. And they position it between the two beds, right where this guy's arm is. Yeah, we actually had a case where somebody's arm got broken because it, bless you, was hanging off of the bed and was hit with equipment and it broke the arm. So the arms really need to think of it like a roller coaster. All hands and arms need to be inside the moving vehicle at all times, right? That's how we look at this. Good? Good. Call light's going to go in the bottom hand, not the top one. Now, this is kind of counterintuitive. A lot of people will put the call light in the top hand. Don't do that, because when you do that, this cord, like if the patient is turned away from me and I'm going to put this in their top hand, this cord can go right over their neck. So this would go underneath the pillow and right in their hand. You notice this whole skill is about safety? Every bit of it about safety. So that means that these steps are going to count really big, all of them. So a question I get asked a lot is, well, how many of these steps can I miss and still pass? The answer is none, because they're all safety. Good. If you were the patient, which one would you want them to miss? Which step are you okay with them missing? None. Okay. So we're going to follow our care plan. We're going to do our opening. We're going to think about gloves. Now, you may need gloves. You might. But for the test, your patient is fully clothed, holding onto all of their own body fluids like a champ, have no open wounds that you're going to come into contact with. So for the test, you do not need gloves for this skill. But in a clinical setting, your patient is probably wearing a hospital gown and not much else. So you probably want to slip a pair of gloves on for this. Good? Do you guys understand the difference? Why? All right, we're going to use a privacy blanket because we have to put a pillow behind their back and between their legs. So that sheet is just going to kind of get in the way. You can do this without a privacy blanket, perfectly okay, as long as you keep them covered with a sheet. But it's really hard to get a pillow between their legs with that sheet in the way. Linen rules always apply no matter what we're doing. Don't hold stuff against your uniform. Nothing goes on the floor. Don't shake or snap anything. We know all this. Scoot and roll. This is how we get our patient to the middle of the bed. We have them scoot toward us and then we roll them. All of our side lying position checkpoints we just talked about. And then we're going to do our closing. Thank you very much, Miss Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine? Which makes no sense for this skill, but we're going to offer one anyway because we want that checkpoint. Here's your call light. If you need anything at all, let me know. Bed is in low position. Environment's clean. Here's your call light. Open the curtain. Go wash my hands. This care plan is only for this patient, not for anybody else. This one can't scoot on her own. We have to use a draw sheet to get her closer to us. This patient up and out of bed, we don't turn him at all. Not even on the care plan. Okay. And this one, she can roll on her own. We just have to remind her every 2 hours to change her own position because she doesn't have the nerve innervation to let her know when her muscles need oxygen. Okay. So understand that every single one of your patients is going to have something different.
Why would a magazine not make sense for them?
Because she's already, we've had to move her, so she's not really going to be able to flip through a magazine. Not when we've got a pillow under her arm and one under the pillow. It just doesn't really make much sense. But we're going to offer it because we want to address preferences. Under the pillow. Yet the bottom hand. Call light goes on the bottom hand because we don't want that cord going across the neck. Yeah, the call light goes in the hand under the pillow, and we're just going to wrap the cord under the pillow. It's just all about safety. You don't want anything over the neck. Okay. Good. Other questions? I'm going to show you this skill, and then we'll take our break. Good morning, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to turn you onto your left side and use some pillows to secure your position. Is that okay?
Yes.
Okay, I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. Now that I have clean hands, I'll get clean supplies. We're going to start with a barrier, and we'll place it on the overbed table. And this gives us a clean place to put our clean supplies. Now I'll get 3 pillows. And a privacy blanket. We'll bring this over to the side of the bed. Okay, Mr. Jones, I'm going to start with a privacy blanket. I'll place this on top of you to help protect your privacy and to keep you warm while we do this skill. So I'll take the privacy blanket and unfold it, being careful not to snap it or shake it. We'll lay it right over the patient on top of the sheet. Can you hold that for me? Thank you. I'm going to pull the sheet all the way down to the end of the bed. This just gets that sheet out of our way. Okay, Mr. Jones, can you scoot your body toward me? Thank you. Now I'm going to position you for the turn. So we're going to take the furthest arm and place it up over the head. The closest arm will cross the chest. The closest knee is going to bend with the foot flat on the bed. And then the furthest knee will angle out. Okay, just relax for me. Thank you. And now I'm going to roll you on your side on the count of 3. 1, 2, 3. So I'll roll the patient, maintaining a wide base of support. And then I'll use some pillows to keep him in this position. So the first pillow will go behind the back. We're going to move the privacy blanket out of our way so we don't tuck it in. The first pillow will go behind the back. We're going to tuck this edge underneath the patient. So I'm going to tuck down and under. This edge will roll up and then under the patient, down and under. And that provides a nice roll. We'll go to the other side of the bed. So this pillow will go between the legs, specifically between the knees and the ankles. We don't want the legs to lay right on top of each other, so I'm going to move the top leg just a little bit forward, and then I'll lift from below and place the pillow in between the legs. That way they're not laying right on top of each other, and the bony prominences are separated by the pillow. We'll cover the patient up. I'm going to take the third pillow, and this one will go underneath this top arm. As the arm droops down, this puts a lot of pressure along the upper back and into the neck. We need that arm in a neutral position. So I'll take the pillow, lift the arm from below, and place the pillow right under the elbow area of that top arm. Now the pillow under the head is under the bottom shoulder. So we're going to lift the head up, move the pillow so that it's only supporting the head and neck, and then we'll place that bottom arm underneath the pillow. We're going to take the call light and place it directly in that bottom hand. Okay, Mr. Jones, I'm going to remove the blanket and pull the sheet up now. So we'll pull the sheet right up over the blanket and the pillows, and then remove that privacy blanket, rolling it into a ball as we remove it so that trailing edges don't contaminate other surfaces. We'll adjust the sheet for neatness and appearance. And we'll open the privacy curtain. Mr. Jones, are you comfortable?
Yes.
Okay, I'm going to go dispose of my linens and I'll be right back. This will go into dirty linen. We'll dispose of the barrier in the trash can. And we'll move the tray table back to storage. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Is the head of the bed, does it need to be adjusted at all?
No, thank you.
Your environment is clean. Bed is in the low position. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right. Any questions on that skill?
If they want to keep the privacy blanket, is there any actual detriment to that?
No, but that's a observation. And what do we do with observations?
We report it to the nurse.
Right. So they can keep the privacy blanket, that's fine, but we want that nurse to know because a decrease in temperature may indicate an infection. Okay. Temperature change.
For testing of the skills on the day of the test, is the skills like placed on a table somewhere? Like, should we not touch after we wash our hands? Should we not touch the care plan?
Oh, yeah. They're not going to grade you on that. Yeah. It will be. So when you go take the test, okay, you're going to get one of these. It won't be the whole packet. It'll just be a single one. Okay. They read it to you. They hand it to you. You put that wherever you want to put it. So if you want to put it on the table, that's fine. If you want to put it on the bedside table, that's fine. If there's a chair laying over there, you want to lay it on there, that's fine. Put it somewhere visible so that you can review it at the end of the skill without having to touch it. Yeah. Just put it somewhere visible. Okay. But yeah, they're not going to grade you on touching the care plan. Good question though. For infection control, good question. Questions? Everybody good? All right, let's go ahead and take our break. Those of you attending virtual, sorry, you haven't missed much. Okay, so let me explain to you this part. Tells you to replace their sock and shoe at the end of the skill. When you are doing this on a live patient in a clinical setting, a real patient, they're going to have clean socks in a drawer somewhere. You're going to be able to go get clean socks because clean feet deserve clean socks. Okay. Remember that this is done in a testing center and you're doing it on another live testing student. That student does not have a pair of socks in their back pocket. So for this skill, for the test, you have to put the sock and shoe that they wore in back on. We understand that in a real life setting, we would put clean socks on. Okay. But for the test, because it's a test, they're going to tell you what to do. That way you're not standing there going, no clean socks. What do I do? We follow the care plan. Care plan's already got it covered for us. Does that make sense? Good. We already know all this. We know to follow the care plan. We know how to do our opening. We know to evaluate if we need gloves. Now, let me time out here on gloves for a second. The whole point of doing this skill, guys, is to look at the foot. It's not to clean the foot. You are there to look at the foot, and that's because feet are almost always covered. There's always socks, shoes. There's always something in the way. Hands, you can see. They're out there. They're not usually covered, right? We can see hands pretty easy. But feet are covered, like always covered. So the whole purpose of this skill is to have an excuse to be around naked feet and look at them. That is why we do this, is to look at those feet. Well, because we haven't seen the feet, we don't know if there's a wound. So there's a maybe here. Because there's a maybe, what do we need to wear? Gloves, that's right. Make sense? We're going to use a barrier, but this time we're not going to put it on the table. You can't get your foot on this table to do foot care. Okay. I mean, some of you might be able to, but your patients are not going to be able to put their foot on this table to get foot care done. So where do you think the barrier is going to have to go? On the floor. Absolutely. So for this skill, we are going to use a barrier, but it will be positioned on the floor. All of the supplies that we use will go on the barrier on the floor. Good? Don't hold the supplies against your uniform. We know that. All washing rules apply. So we use a paper towel to turn the faucet on. We use warm water, not hot, not cold, just warm. We check it and they check it. Very good. Don't add soap to your basin. We need water for rinsing. Whatever you wash, you rinse. Whatever you rinse, you dry. We know all this. If the water gets cold or soapy, change it. And if we're going to put lotion on, we warm it up first, we put it on, and then we wipe off the excess. Good? We're going to clean that basin the same way we clean all other basins. We're going to rinse it, we're going to dry it, and we're going to store it. And we're going to do the closing. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here? Are you comfortable? Would you like a magazine before I go? Environment's clean, bed's in the low position. Here's your call light. Open the curtain, wash my hands. My skill is done. Right? We end the skill the same way. You guys should be rolling your eyes by now. Are you rolling your eyes yet? Maybe by Monday. Because all of these are steps that we've done over and over and over, and they never change. Good? Good? All right, so let's put this together with the skill-specific steps. So hand care, hand and nail care and foot care are very, very, very much alike. We put the hand in the basin to soak. We're going to put the foot in the basin to soak. We put the hand out of the basin on a towel. We're going to do the same thing with the foot. Take it out of the basin, put it on a towel. We're going to wash the hand. Well, we're going to wash the foot. Then we're going to pick that hand up and put it back in the basin to rinse it. What are we going to do with the foot? Pick it back up and put it back in the basin to rinse it. Same steps. But with hand and nail care, we cleaned under the nails with an orange stick. We don't do that with foot care. We don't do anything with nails. Nothing with nails. With hand and nail care, we filed the rough edges. We're not going to do that with toenails. We don't file. We don't do anything with toenails. We do not clip. We do not file. We do not clean. We do nothing with toenails except look. Now, if the patient's toenails need a little bit of attention, and they probably will, who do we tell? The nurse. There is a podiatrist or foot doctor that comes to long-term care facilities once a month. The CNA does foot care, notices there's a problem, tells the nurse. The nurse puts the patient on a list to be seen by a podiatrist. When the podiatrist comes in, they don't go room to room. Do you need me? Do you need me? Do you need me? They don't do that. They go in, they look at the list. If the patient's on the list, they get seen. If they're not on the list, they don't get seen. So you doing foot care is to figure out whether they need to be on the list.
Who maintains their toenails?
Podiatrist.
So they cut the nails and everything?
Mm-hmm. Podiatrist. That is correct. Yep. Yep. We're going to explain why in just a minute. Okay. All right. So once we have looked at all surfaces, I'm looking for red areas, wounds, rashes, sores, toenail issues, fungus, ingrown toenails, bunions, anything that makes me go, huh, that's not normal. I would let the nurse know. Once I've done all of that inspection, I'm going to apply some lotion. I'm going to warm it up my hands and put it on the skin except between the toes. No lotion between the toes. Lotion holds in moisture. Between the toes, we already have warm and we already have dark. If we put moisture there from washing and then we put lotion on top of that moisture, it'll hold that moisture in place, and that leads your patient to the potential for athlete's foot or other fungal infections. So no lotion between the toes. Everywhere else is fine, but not between the toes. Then we're going to put their sock back on, smooth it out, no wrinkles. You guys remember how dangerous wrinkles are. And then we're going to put the shoes on. Then we'll clean up and do our closing. So it's very much like hand and nail care, but we're not going to do anything with the nails. And they give us 8 minutes to get this done. That's a lot of time to wash one foot. Okay, good? Good. All right. So to do this, we're going to put the basin on the barrier, and we're going to put the foot in the barrier to soak. We're going to make sure that we support it as we lift it and move it. We're going to wash, rinse, and dry the entire foot, just like we did the hand. We're going to look for any abnormalities. We're going to apply lotion to all areas except between the toes. But this is our main job, to look for anything unusual. Keep the foot on the barrier, no bare feet on the floor. The only thing that can go on the floor is shoes. No bare feet on the floor. Replace the patient's sock, trying to remove their wrinkles, and then their shoe. Questions? Okay. We're going to talk a little bit today, just very briefly, about diabetes and why we need to look at the patient's feet. We're going to talk a little bit more about diabetes next week. Okay. So what I need you to understand is that the effects of diabetes are much more pronounced in the hands and the feet of your diabetic patients. And that's because sugar, excess sugar in the bloodstream, is a very heavy crystal, and it gets pulled down with gravity. And the lowest points of my upper body are my hands. The lowest points of my lower body are my feet. So when you have high blood sugar, that molecule, that crystal, is going to get pulled down to the hands and the feet, and it's going to coat the inside of arteries. It'll coat the outside of nerves. It does a lot of really bad things in the body, and your diabetic patients are likely to have more issues with hands and feet than other areas of the body. And that's one of the reasons that we have to look, because with diabetes, it actually coats the nerves themselves. So your patient may have been walking around, stepped on something, injured their foot, and have absolutely no idea that that injury exists. They can't feel it. They can't see it because we get less bendy as we get older. We're not looking at the bottom of our feet. So they have no idea that wound is there. And because they don't know the wound is there and it's covered with socks and shoes all the time, it is warm, it is dark, it is moist, and that wound probably will not heal on its own. Good? Make sense? This is why we do foot care, to look at the foot, because it's most commonly not looked at on a regular basis. Most people in long-term care settings will have foot care performed once a week. And basically, you're just there to look. Okay? Good. All right, so let's put this all together. We're going to follow that care plan. We're going to do our opening. We're going to wear gloves because there's a maybe here. That's the whole reason we're there. We're going to use a barrier, but this time it goes on the floor. We're going to follow our linen rules. We're going to follow our washing rules. We're going to clean our basin like we clean all other basins. And we're going to do our skill-specific steps. Wash, rinse, dry, look. Lotion everywhere but between the toes. Don't do anything with the toenails. And then you can do your closing and finish up. This care plan is just for this patient. That's it. This patient, she doesn't get foot care. She showers herself. She looks at her own feet. She's still pretty bendy. She's good. Doesn't need us. That older lady up at the top, she gets foot care, but she goes to the salon once a week and she has pedicure done. And that's where she's going to get her foot care performed. And that gentleman there, he gets foot care, but he is a very brittle diabetic, and we've got his foot care twice a week because he's particularly at risk. And as much as we try to get him to wear shoes, the man walks around without shoes, and that's a risk factor. So I've got you doing foot care on him twice a week. Do you guys see how every care plan is going to be a little bit different based on the needs of the patient? Questions on this?
I have a question.
Sure.
Regarding of gloves, we put when we wash the foot, right?
Mm-hmm.
And then at the end we put lotion. We still keep using the same gloves, or we
Yep.
have to change it?
No, you can use the same gloves. It's fine. It's fine.
Thank you.
Yeah. Let me clarify that a little bit. If I'm working on this lady and we do foot care on her every week and she's in a confined area and I know what I'm working with and her feet aren't that dirty, then yeah, I'm not going to change my gloves. If I'm working on somebody who's been homeless the last 6 months and hasn't even seen a shower in 6 months, yeah, I'm going to be changing those gloves out. Absolutely. Because the gloves are what we call grossly contaminated. Okay. You're welcome. So that's really a little bit of a judgment call there.
So what if you're like one of your patients, let's say it's an elderly patient, and she just so happens to have like scabbing on her, and I know to wear gloves, but what about the water in the basin if it gets like bloody? Can you get up and change the water and maybe
Absolutely. Well, we're going to change the water if it gets cold or soapy, or I should add icky to that. Okay. So if it's icky at all, we're going to change that water because I don't want to put her clean foot. I just washed her foot. I don't want to put that clean foot in a icky water to rinse it.
And then we would then afterwards let the nurse know she could dress the wound after it's done cleaning or in the mix?
So that's a very good question. If you notice any open wounds, stop what you're doing because I may not want soap in that wound. Okay. That soap is, depending on the type of soap we're using, can be very abrasive to wound tissue if it's an open wound. So I may not want soap on there. And now there's other wounds that I want, cleaned with soap. It depends on the type of wound that it is. So anything that you notice like that, if it's an open area, stop what you're doing and go get the nurse. Now, let me give you a scenario that actually happens a lot. So I assign you to go do foot care. You go do foot care. You see an open wound. You finish foot care. You put the shoe and sock back on. You send the patient to activities, and then you come let me know. Hey, this guy's got a huge wound. You should see it. It's like a crater. It's like bloody and awful and icky and disgusting. Oh, and it smells too, by the way. I'm going to go, okay, where is he? And you say, oh, yeah, he's in activities. What am I supposed to do with that? Go get him, take him back to his room, take his shoe and sock back off so I can take a look and see what's going on, right? Where if you just stopped what you were doing and gone to get me and said, hey, this guy's got an open wound. It's like a crater and it smells bad. I'm going to stop what I'm doing, go look at it, and then give you instructions from there. Okay. And that's probably going to involve me getting some measuring tape and a camera, and we're going to document all this. I'm going to call the wound care specialist and the family and the doctor. And yeah, it's going to be a big deal. But at least we can get it started a little bit earlier than you getting him all buttoned up and sending him on his way. And now we got to go find him. Right. Yeah. In a sweaty shoe. Yeah. You're welcome. So the sooner you can let the nurse know about the changes that you're seeing in the patient, especially open wounds, especially anything open. Because remember, open wounds are always a doorway in. And that's what I'm concerned about here. Good? Good? All right, so we're going to go ahead and watch this video on foot care. Hello, good afternoon, Mr. Jones. My name is Patty, and I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I'd like to perform foot care on your right foot per the care plan. Is that okay?
Yes.
Let me close your privacy curtain, wash my hands, and get my supplies, and I'll be right back. After washing my hands, we'll gather our supplies. We're going to start with a barrier on the floor under the patient's feet. So we'll spread the barrier out. And can you move your left foot to the side, please? Thank you. I'm just going to place this barrier on the floor. If you can lift your foot. Thank you very much. And we'll move that shoe out of the way. We'll also need a basin, soap, and lotion. Once the barrier is in place, we're going to get 1 towel and 2 washcloths and take them to the patient's area. You can place a barrier on the floor to kneel on, but this is optional. All right, Mr. Jones, I'm going to go get some water in the basin. I'm going to use a paper towel to turn the water on. Check the water temperature with the inside of my wrist. It should feel warm, not hot or cold, just warm. And we'll fill the basin about 1/4 of the way full. And then throw the paper towel away. Mr. Jones, would you like to check the water temperature?
Oh, that's beautiful.
Very good. I'm going to set this down. For this skill, I need 1 set of gloves. I'm going to go ahead and put my gloves on before we get started. And then I can take your sock off. We're just going to lift your foot and remove your sock. We'll set your sock to the side being careful not to overextend, and place your foot into the basin. After your foot has soaked for a few moments, I'll place the washcloths in the basin and rinse your foot, and then lift the foot out and place it on the towel, wringing out one of the washcloths and applying soap. We'll apply soap to the top leaf and then wash all surfaces with short, soft strokes or a patting motion. We're going to wash down each one of the toes and then get in between the toes. And then gently we'll lift the foot with support and inspect the bottom of the foot while we wash all areas from top to bottom. And then we'll set this washcloth aside and place the foot back in the basin to rinse. We'll use the second washcloth to rinse the foot, squeezing the water to make sure that the foot has been rinsed well. I'm going to unfold the towel and lift the foot and place it on the towel to dry. We'll blot the foot dry around the ankle, the top of the foot, the heel of the foot, and then we'll lift the foot gently to dry the bottom. We'll take an edge of the towel and slide it gently in between each toe to blot to make sure no moisture remains behind. Now that the foot is dry, we'll get some lotion, warm it up in our hands, and then apply it to all areas of the foot except between the toes. So the top of the foot, the heel of the foot, and the sole of the foot, but not between the toes. And then we'll wipe off the excess lotion. The care plan has told us to replace the patient's sock. So once the lotion has been removed, I'll take the sock, make sure it's right side out, and scrunch it all the way up to the toe seam. We'll put the sock over the foot, making sure the toe seam lines up across the toes, and then we'll secure the sock over the heel, minimizing wrinkles and making sure the sock fits appropriately. And then we can gather our dirty linens and place them in the soiled linen hamper. So we'll place our soiled linens in the soiled linen hamper. Now we can clean our basin. I'll bring the basin to the sink. We will dispose of the water in the sink, rinse the basin, and then dispose of the rinsed water in the sink as well. I'm going to set the basin down, disinfect it per facility policy, and then use a paper towel to pick it up. We'll dry the inside with a paper towel. Throw that paper towel away. Dry the outside with a paper towel and throw that paper towel away. And then get one more for the drawer. After cleaning the basin, we'll use the paper towel to pick up the soap and the lotion and return the basin to storage. We're going to put our supplies away by opening the drawer with a paper towel. We're going to put the basin, soap, and lotion in the drawer, close the drawer with a paper towel, and then we'll throw the paper towels away. And then we'll remove our gloves, being careful not to contaminate our hands. So now I'm going to gather the barrier, and we'll throw this away, and I'll help you put your shoe back on. There you go. Are you comfortable?
Yes.
Is there anything else I can get for you while I'm here?
No, thank you.
Would you like a magazine before I go?
No, thank you.
Your environment is clean. I'm going to go open the curtain and give you your call light.
Thank you.
Okay, Mr. Jones, here's your call light. If you should need anything at all, just press that red button. I'll be happy to come back and help you.
Thank you.
Is there anything else I can get for you before I wash my hands?
No, thank you.
Okay, have a great day. I'm going to go wash my hands. After washing my hands, I'll review the care plan, make any corrections, and tell the evaluator my skill is done. All right, questions? Questions. It's a whole lot like hand and nail care, just lower.
So, and you said they grade, like when we wash our hands, they grade us on bubbles because that soap is different. Do they have any specific like things when you're spraying like the spray soap?
So when we're washing our hands, bubbles count. When we're working on a patient, they don't. And that's because the soap that we use on the patient is specially formulated not to suds. Yeah. It's supposed to be easy rinse because they know that we're not in a running water situation. Okay, great question. All right, any other questions? We're going to move on to page 92. This is performing mouth care to a resident with teeth. We have a whole nother skill for dentures. Whole nother skill for that. That's not this skill. This is just plain old brushing teeth. There's nothing for me to teach you here, guys. If you've brushed your teeth this month, you're pretty much up to speed. Okay. But we are going to go over a few very specific things that I want to bring your attention to. Along the bottom of this, you'll see test specific information. They're giving you 12 minutes to brush somebody else's teeth. 12 minutes to brush somebody else's teeth. And they're not even timing how long you're brushing their teeth for. Like you don't have to brush for 2 minutes. As long as you get all the surfaces, they don't care how long it takes. Okay, but they're giving you 12 minutes to do this. Now, it might surprise you to know who you're going to be doing this on. Another testing student. That means that you may be a patient for somebody else to brush your teeth. And yeah, it's awkward. It is awkward. From the time that you learn how to brush your teeth, you don't want anybody else in your mouth doing it for you. I get it. But do you know who else feels that way? The patient. Patients will continue to brush their own teeth for as long as they're physically able to do so. We don't do this skill on everybody. We do it on the people that we need to do it on because they're physically unable to do it themselves. Page 93 has our care plan at the top, step-by-step instructions and supplies at the bottom. Let's take a look at our care plan. It says a resident with natural teeth is lying in bed. Is that a safe position? No, so we need to get them sitting in an upright position for this skill. The resident is not able to provide their own mouth care. Pretty simple care plan. We're going to use all of these principles that we already know. We know to follow the care plan. We know to do our opening. We are going to wear gloves because there's body fluids. We know to use a barrier. We know linen rules. We know how to clean the basin, and we know how to do our closing. There's nothing new here. Let's look at our skills-specific steps. Again, not a whole lot of earth-shattering newness here. Your patient is lying down, so we need to get them to a sitting position. Now, this is where it gets a little dicey for students because we know that we can't touch that patient until our hands are clean. We've learned that. We also know that that bed controller is touched by everybody that walks in the room. So can it be considered clean? No. Okay, so we got a problem here. We got to put the head of the bed up. We know the bed controller is not clean, and we know we can't touch the patient until our hands are. So when you put the head of the bed up, there's something that you probably haven't thought about. That pillow behind your head when you're laying down in bed, super comfy. We like pillows behind our head when we're laying down. But when you put the head of the bed up, that pillow behind the head forces the head forward, but not the body. This is not comfortable, people. So when you put the head of the bed up, they're stuck like this. You can't adjust that pillow because your hands are not clean and you can't touch your patient until your hands are clean. That's a problem. So your patient's stuck like this while you go wash your hands. Not comfortable. But we don't want to touch the bed controller after we've washed our hands because now we've got clean hands and the bed controller's not clean. So when do I do this? So the simple answer here, the easiest answer here is to do your opening and go wash your hands, just like you always do. Knock, knock, knock. Hi, Miss Jones. My name is Patty. I'm your CNA. Today, I'm here to brush your teeth. Is that okay? Awesome. I'm going to close curtain, go wash my hands. Now I'm going to put the head of the bed up, but what could I use between my clean hands and that dirty controller? Paper towel. We already know this. We just hadn't stopped to put it together. Okay. So we use a paper towel, put the head of the bed in an upright position, and then we can throw that paper towel away and slide that pillow down, and our patient is not uncomfortable. Good? Good? All right. That's the hardest part of the skill. That's the hardest part. Okay. Remember, pillows behind the head when they're sitting up is not a comfortable position. So we have to wash our hands before we touch our patient. So our step-by-step instructions tell us to wash our hands and then use a paper towel to put the head of the bed up. Now we're going to put a towel over their chest just to keep their clothing dry and clean while we brush their teeth, because sitting up is not the same as sitting forward. Think about how you brush your teeth. You're leaning over a sink. Sitting up is not the same, so we want to protect their clothing. We're going to wet our toothbrush, and then we'll put some toothpaste on it. Let me talk to you about toothpaste a minute. Toothpaste commercials used to be on TV. You don't see too many of them anymore, but you may see them on social media or whatever. And the thing about toothpaste commercials that always makes me kind of laugh is they always use this big loopy stripe thing, right? This whole big curly cue of toothpaste. But if you read the boxes that tells you how to use toothpaste, it'll tell you to use a pea-size amount. So their visuals is this big old loopy thing in a box, which you have not read. Nobody reads the toothpaste boxes. Will tell you a pea-size amount. So why is there a difference there? Because they know that you will go by what you've seen, not what you read. And if you see a big old stripe of toothpaste, that means that you're going to use a big old stripe of toothpaste, which means you're going to run out of toothpaste a little bit quicker and you're going to buy more toothpaste, right? So when you're at home, you're probably used to using a lot of toothpaste because that's what you've seen in advertisements. The problem is that when you do that with a patient that is not at a sink, you use a lot of toothpaste and we brush this person's teeth, we're going to be rinsing for like an hour. There's so much toothpaste in there and it becomes a choking hazard because they have no sink to spit it into. Does that make sense? Pea-size amount, all we need. Okay. We're going to brush whatever they got. Top, bottom, front, back, tongue. Brush it. Nobody's timing you on this. If it takes 40 seconds, it takes 40 seconds. Just get all the areas. If it takes 3 minutes, you're dawdling. Okay. Get in there, brush all surfaces, get done. Good? Make sense? You got 12 minutes to get this done, guys. Don't rush it. But you don't have to wait a ton of time either. This patient really doesn't want you in their mouth. Now, in a clinical setting, if we're really doing this for real on a real person, for real, because they really can't brush their own teeth for real, do a good job. Do a good job. You're the only thing that is standing between them and significant dental decay. We're going to let them rinse as much as they need to. And believe it or not, they're going to need to rinse a lot, even if you only use a little bit of toothpaste. Because when you're brushing your teeth, so here's a good experiment for you. Sometime this weekend when you're brushing your teeth, don't lean over the sink. Sit back and brush your teeth. Stand back. Don't lean over the sink. Don't let all of that extra stuff fall out. Keep it in your mouth. You'll realize real quick that that's uncomfortable. You got way too much going on in there. So that will help you understand less toothpaste is more. But also, this is a choking hazard for our patient because they've got all of that in their mouth for a long time. Good? Good? All right. So we're going to let them rinse and spit as much as they need to. Now, this step right here is the one that's missed 90% of the time. Don't forget to dry them off. We get so excited that we're done with the skill, right? We wet our toothbrush, we put some toothpaste on it, we scrub-a-dubbed, we gave them some rinse water, we let them spit. We are done. It is awesome. I can end my skill. All I got to do is put my stuff away and clean my basin. We're kind of on sonic speed now. Get it done, get it done. And we forget to look at the patient, and they are a drippy, wet mess. Are they comfortable? No. Take a minute to look at your patient. Dry them off, please. This is missed way more than it should be. Dry your patient's mouth. You're not going to brush everybody's teeth. If they can brush their own, we're going to let them. Now, as we get older, we may have trouble squeezing the toothpaste. So you may have to help them put toothpaste on. They may need some help putting their toothbrush away. You may have to help them with that. But when it comes to the actual brushing, as long as somebody can hold the toothbrush and brush their own teeth, they'll continue to do that on their own because they are not going to want a stranger in their mouth. Good? Good. All right. So we now know all the steps. Let's use them to check off our checklist. We are going to follow the care plan. We are going to do our opening. We are definitely going to wear gloves because there's body fluids involved here. We're going to use our barrier. We are going to follow linen rules. We're going to clean our basin like we clean everything else. We are going to do our skill-specific steps. And we're going to do our closing. And we're going to get all of those checked off and get a perfect score because that's what we do. Good? This is only going to be done on this patient. This one brushes her own teeth. That one has dentures, and that guy, we do mouth care on him, but he stands at the sink for it. She's the only one that's in bed. Notice that all of our care plans are different. Good? Let's watch this video. We have one more skill coming up. It's not going to take me very long. I'm like 2 or 3 minutes off, so bear with me. We have one more skill to do after this one. It's not very long. And then we're going to get into test registration. So not during this skill, but the next one, Jake's going to be passing out papers while the video is going, and then we'll roll right into test registration. All right, Jake, take it away.
Hello.
Good morning, Mr. Jones. How are you?
I'm well. How are you?
Fantastic. I'd like to perform mouth care on you. Is that okay?
Yes.
I'm going to close the curtain, wash my hands, get my supplies, and I'll be right back. I'm going to use a paper towel as a barrier to put the head of the bed up, since my hands are clean and the bed controller is not. Once we get the patient to an upright sitting position, I can throw the barrier away and then adjust the pillow so it's a little more behind his back rather than his head. There we go. Good?
Yes.
Okay, let me go get the rest of my supplies and I'll be right back. I'll gather my supplies. We're going to start with a barrier, and that gives us a clean place to place our clean supplies. So we're going to open the barrier up. And I also need a towel. We're going to get an emesis basin, a toothbrush, toothpaste, and a cup of water. And we also need a pair of gloves. I'm going to get my toothbrush prepared by wetting it and putting toothpaste on, and then storing it in the emesis basin until I'm ready to use it. Mr. Jones, can I place this towel over your chest?
Yes, please.
Thank you. This is just going to help keep your clothing clean. I'll put my gloves on. And now we're ready to brush your teeth. I'm going to brush the top, the bottom, the front, the back, and your tongue. So can you open wide for me? I'll start in the back, on the top, both sides. And then the bottom, both sides, the front, both top and bottom. And can you bring your teeth together? Thank you very much. And then stick your tongue out. Thank you. I'll set this aside, and now we can rinse. Go ahead and take a sip. Another sip?
Yes, please.
Okay. I'll pour the water in the emesis basin, set them on the table, and then I'll take this towel away and put it in dirty linen. I'm going to go clean my basin. We'll clean the emesis basin by dumping the saliva into the sink, rinsing the basin, setting it down, and disinfecting per facility policy. Then we'll take a paper towel to pick it up, a paper towel to dry the inside. We'll throw that paper towel away. Paper towel to dry the outside, throw that paper towel away, and one for the drawer. Now I can return the basin to storage, putting the toothpaste in the basin and using a paper towel to open the drawer to store the basin back in it. We'll close the drawer with a paper towel and then throw those paper towels away. All of these disposables will be disposed of. I'm going to go throw this away. I'll be right back.
Okay.
Now I can remove my gloves. Okay, Mr. Jones, is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes.
Okay. Bed is in the low position. Your environment is clean. Let me get your call light for you. Would you like a magazine before I go?
No, thank you.
Okay. Here's your call light. If you need anything at all, just press that red button. We'll be happy to come in and help. I'm going to go open your curtain and wash my hands. After washing my hands, I'll review the care plan, make any corrections, and then tell the evaluator my skill is done. I get asked a lot is at the end of the skill, do I have to put the head of the bed back down? And the answer is no, that's up to the patient. It's his preference. Head of the bed can be up or down. Now, if the care plan indicated, then I would have to address that. But as long as the care plan doesn't tell me what position the head of the bed needs to be in, it's wide open to the patient. Okay.
So we use the toothpaste once and throw it out?
No, the toothpaste gets used over and over. The toothbrush in a clinical setting will get used over and over. But for the test, your patient isn't going to be there in 3, 2, 1. So we're going to throw it away because you don't want to use, remember, this is a live patient skill. She doesn't want the toothbrush that was used on you, used on her. So we're going to throw it away for the test. It's disposable. But in a clinical setting, we're just going to rinse it out and store it like we store everything else for the patient to use over and over.
Since you said like putting the head up or back down, does
Only if it specifically, if it said that the patient needs to remain in a supine position, head of the bed flat, and the patient says, hey, can you leave the head of the bed up? You would have to say, I'm sorry, the care plan has me putting it down, but I can let the nurse know. Yeah. Yeah, only when it contradicts the care plan. Okay. Good? Questions? All right. Let's get into our last skill for today, which is respirations, and then we will go through the test registration process. All right. So respirations is on page 54. This is our overview. Our principles are spelled out here. We've got some skill-specific things to go over. Down here is your test information. Somebody with your level of experience, which is none, should be able to do this skill in 5 minutes or less. It's going to be done on a live testing student, and that person will be positioned in bed. That actually helps, guys. You can see somebody breathing a whole lot better when they're laying down. Just watch their tummy move up and down. Makes it easier to see the breathing. You can count respirations with somebody sitting up. It's just a little harder. And the test is trying to make it easy on you. So for the test, your patient will be laying in bed. Good? This is a documentation skill. So that means that you're going to have to document the number that you get. Basically, anytime in healthcare that we count something, we got to write it down. Because having it in your brain doesn't do me any good. If I'm telling you to take respirations, I need that number for something. If it's stuck in your head, I can't use it. Okay? So normal is between 12 and 20. We'll get into that in a minute. And you can be off by 2 breaths in either direction and still be accurate for the test. That's your variance. So let's say that you counted respirations and got 16. If the evaluator got 14, 15, 16, 17, or 18, you're still considered accurate. Guys, that's half of the range. They give you so much latitude with this. Okay, good. Good. 2 either way, on either side. All right, so page 55 has our care plan at the top, has step-by-step instructions, has your supplies at the bottom. Here's your care plan. Patient will be lying in bed for skill. Count the patient's pulse for 1 full minute. How long are we counting? 1 full minute. If the care plan doesn't specify, you can count for 15 seconds and multiply that by 4, just like with the pulse.
It says, don't tell the patient you are.
We're going to get, yep.
It also says to say start and stop.
Okay, hold on 1 second. We're going to get there. Okay. All right. It says count respirations for 1 full minute and record your readings. We know all of the principles involved here. So let's look at our skill-specific steps. So the first one is what you just mentioned. Don't tell the patient that you're counting their breathing. And this is really, really important because if I tell you, I'm going to count your breathing. Ready, set, go. Yeah. So either the patient stops breathing or they start breathing fast because we've made them anxious. And we're aware of it. Breathing is meant to be subconscious, which means that we're not really paying attention to it. But it's one of those processes that you can actually impact yourself consciously. You can take a deep breath. You can speed up your breathing and slow it down. You can't do that with your digestion. Right? I can't concentrate real hard and make digestion happen. Right? So it is a subconscious process that has direct conscious control. And that's what happens here. If we tell somebody, I'm counting your respirations, you're putting it under conscious control, which is then going to alter our reading. Does that make sense? So I'm not going to tell somebody, I'm going to count your breathing or I'm taking your respirations. What I'm going to say instead is I'm taking your vital signs. Respirations is part of vital signs. Perfectly okay. But it doesn't clue our patient in exactly what we're doing, which means that we should get something a little closer to baseline. Does that make sense? Good? Good? All right. So for this patient, I'm going to say, knock, knock, knock. Hi, Ms. Jones. My name is Patty. I'm your CNA today, and I'm here to get your vital signs. Is that okay? Close curtain, wash hands, get supplies. That's it. This is kind of important for accuracy so that we're getting something accurate. In and out is 1 cycle. So that was 1 breath, not okay. In and out count as 1. That whole thing is 1. Make sense? So when you're counting, if you start counting and the patient is exhaling, you're going to count it because it's part of the whole. Okay. All right. So in and out counts as 1 cycle. Now we're going to count as long as care plan tells us to. This care plan says 1 full minute. So how long are we counting? 1 full minute. Don't take shortcuts. For whatever reason, the nurse wants a full minute count on this patient. If the care plan doesn't specify, if the care plan doesn't tell us 1 full minute, we can take shortcuts. We can do the 15 seconds multiplied by 4 to get our reading. Now, normal breathing is between 12 and 20. That's what we're hoping to get, somewhere in that range. What would we do if we got 10? Report it to the nurse. What would we do if we got 32? Mm-hmm. Quickly. Yeah. So here's the problem with breathing that is too fast. If I'm breathing 32 times a minute, which looks like this, that's about 32 times a minute. Okay. If I'm breathing that fast, what happens is that air has to go into my airway, down through my bronchioles, and into the alveoli, or the little air sacs. Well, by the time it gets halfway there, I'm exhaling and pushing it back out. So it didn't get to where I needed it to go, which means that I'm probably not oxygenating well because it's just too fast for that oxygen to get from the air into my lungs. Make sense? If I'm breathing too slow, so normal is between 12 and 20. So if I'm breathing like 8 or 9 or 10 times a minute, it would look like this. That may not be enough oxygen to oxygenate my entire body. Now, this happens with opiate overdoses. One of the first things that gets affected with an opiate overdose is the respiratory center of the brain gets put to sleep, and the patient just stops breathing. That's a bad thing. Now, we would think that this would never, ever, ever happen in a clinical setting, and I'm going to tell you that is absolutely wrong, because patients that have opioid addictions are not going to stop their opioid addictions just because they're in a clinical setting. They're going to have their friends, their family members, their dealers come and bring them their drug of choice. They're not going to ring up the nurse and say, hey, by the way, taking a little fentanyl now. Okay. Now, we're also giving them medication, and the medication we're giving may or may not affect the potency of that drug of choice. So we can have overdoses in a medical setting because a patient took something from the outside that we weren't aware of. So you need to pay attention to this. But it can also happen as a direct result of the drugs we give them. Because if they have a metabolic dysfunction and we give them pain medication, it may stop their breathing or slow it down considerably. So all patients in all settings should be monitored for any sort of respiratory abnormalities. Make sense? That's why we do this. Because we're concerned about their oxygen. Normal is between 12 and 20. Now, the evaluator has to count with you. That's just a fact of testing. The evaluator has to count with you. We want them on the other side of the room. We don't want them hanging over our shoulders. We want them over against the wall. I'm going to show you how to do that in a minute. But they've got to know when you start counting and when you stop counting so they can start and stop at the same time you do. So when I'm doing this skill for the test, I'm going to look at the clock and I'm going to say start when the second hand gets wherever I want to start. And then I'm going to count the respirations. Remember, in and out equals 1. Until that second hand gets all the way around to that starting point, and I'm going to say stop. Now, we're only doing this for the test. You're not doing this in real life. We're only doing this for the test because we're being tested. Does that help you? Okay. We are not going to tell our patient that we're counting their respirations, and we're only saying start and stop because it's a test. We'll say vital signs, right? Right. Does that help?
Yes.
Okay. All right. So we'll say start when we start counting. We'll say stop when we stop counting, and hopefully they'll get around the same number that we do. That's kind of the goal. Hopefully they'll get around the same number that we do. Documentation principles. I have a whole lesson on this on page 48. I'm not going to go over that in class because we're running low on time, but you can read this on your own this weekend. So here's our steps. We know these principles. We're going to use it to check off this checklist. We're going to follow our care plan. We're going to do our opening. I'll evaluate if I need gloves. Chances are I probably won't. But I'm going to evaluate if I need gloves for this. And I'm going to explain to you in just a minute why we might. But give me a second. I'm going to follow my skill-specific steps. I'm only getting 1 check mark here. Just 1 for skill-specific steps. That's it. Then I'm going to do my closing. Okay, so that's how we're going to get these checked off. But let me show you something really quickly. If I stand over this patient, okay, I'm going to count her respiration. She's laying in bed. If I stand over this patient, ready? Start. How comfortable do you think she is? I am quiet for an entire minute. And guys, do you know how long a minute is? So I am silent, staring at her chest for an entire minute. This is extremely uncomfortable for your patient. And you know what they're going to do when they're uncomfortable? They're going to talk. What's wrong? What's going on? Am I dying? Is everything okay? They're going to have a million questions for you, and you have totally lost count. So we've got to start over. So the best thing to do here is to not stare at somebody silently. It's just not cool. So what I'm going to do instead is make them think I'm taking the pulse. I'm going to hold their wrist. Now, I'm not finding their pulse. I'm holding their hand, basically, but I'm going to hold here. Now, my patient's focus is here. They know that when we're taking a pulse, they must remain quiet. So this is familiar to them. It's also less uncomfortable. I can look at their chest, but they don't think I'm staring at them. This normalizes this process. Does that make sense? So we're using a little psychology here. So I'm going to keep the elbow on the bed, hold the wrist, holding their hand, and I'm going to look at the clock and say start. Now I'm going to watch the chest rise and fall until the second hand gets all the way around, but my patient is focused here, not here, so it's less likely to affect their breathing. Good? Now there's something you can use to help you with this. If I'm staring at somebody's chest, it's really hard to see their chest go up and down. I mean, it's visible, but it's not really visible. Now I want the best chance of success here. So during the test, I am going to put an alcohol pad. There will be an alcohol pad right on top of your 3-drawer unit. I'm going to put an alcohol pad on their chest. What that does is it increases my ability to see the movement of the chest. It does not affect her breathing at all. It's psychology. I'm working with my brain, not her body. Now, what this does is your brain is trained to pay attention to movement when it's a contrasting color. This is what kept you safe when saber-toothed tigers were roaming the jungle, okay? Your brain is trained, okay, color, Moving, danger. So your brain will pay attention to when we put an alcohol pad on their tummy, doesn't matter which side you use. This is a different color. There's blue on here. It's a contrasting color. So as that chest rises and falls, my brain is going to be able to pick it up a little bit more. Make sense? It also means that that evaluator can hang out on the wall and still see the rise and fall of the chest. They're not going to be hanging over your shoulders, which is awesome for our own anxiety. Good. You can use that on the test. Put an alcohol pad on their tummy and you can watch it rise and fall a whole lot easier. You're going to see that in the video that I'm going to show you. All right, any questions? This care plan, only for this patient. My ear is in the wrong place. This care plan only for this patient, not for this one. Not for this one. Not for this one. Not for this one. This one, we don't even take her respiration. She's good. She's even. She has no conditions that we have to really monitor her breathing. We're not doing respirations on her. This guy, he's pretty stable. We do his for 15 seconds, multiply that by 4. This one, she has cystic fibrosis. Her breathing is all over the place. She's had it her entire life. The fact that she's made it to this age is frankly a miracle. And we don't do her respiration reading. The nurse does because it's super critical. Good? Good. All right, let me show you this video. It is literally a 2-minute video. It's going to be super quick, but do you guys remember Pulse? Remember us doing Pulse? You guys remember that? Remember the video for Pulse on the bottom of the screen? It went big and small so that you could count along with. Well, I do the same thing for respiration. You'll see in and out, because I know with camera angles, it can be kind of hard to see the inhale and exhale really effectively. You'll still be able to see it on the screen, but I bring it to your attention on the bottom. Count with me, and then at the end, when I document, see if you got the same number. Okay, does the alcohol pad count in the grade? No. You can use it. You don't have to use it. It's there for you to use if you want to. You can use it in a clinical setting if you need to, if the respirations are really hard to see. So no, the alcohol pad does not really count either way. Use it or don't. All right, Jake.
Hello.
Hi, Mr. Jones. My name is Patty. I'm your CNA today. How are you?
I'm well. How are you?
Fantastic. I need to get your vital signs. Is that okay?
Yes.
I'm going to close your curtain. Let me go wash my hands, and I'll be right back. Okay, Mr. Jones, I'm just going to lay this on your stomach for later. I'm going to elevate your forearm, keeping your elbow on the bed. And this will take me about a minute. I'll need you to remain quiet during that time, but I'll let you know as soon as I'm done, okay? And we're going to start. Ready, set, start. Stop. Thank you very much, Mr. Jones. Is there anything else I can get for you while I'm here?
No, thank you.
Are you comfortable?
Yes, ma'am.
Would you like a magazine before I go?
No, thank you.
Okay, bed's in the low position. The environment is clean. Here's your call light.
Thank
If you need anything at all, just press that red button. We'll be happy to help you. I'm going to go ahead and open the curtain and throw my alcohol pad away and wash my hands. After washing my hands, I'm going to document on the sheet provided by the evaluator and then wash my hands again. After washing my hands a final time, I'm going to review the care plan, think about my skill, make any corrections, and then tell the evaluator my skill is done. All right, any questions? Did you guys get about the same number that I did? Not a hard skill. Okay. We are going to go through the test registration packet now. I'm going to give you a lot of information in a very short period of time. I need you to know that if you go to foryourcna.com, under testing, I have test registration instructions. This is a video that walks you through the entire test registration process, because you probably will have questions after this. Whoops. Okay. So in your packets, oh, Jake, we need the other flyer. So Jake's going to pass this out. Yep. So this is two-sided. These are the 4 steps to the test registration process. So it's just as easy as 1, 2, 3, 4. It's going to look a lot more complex than this, but what you can really simplify it down to 4 steps. The first step is to obtain a background check. We're going to talk about that in just a minute. The second step is to register for the test. We're going to do that, fill out that registration form in class together. Then we have to wait to be approved for testing. Guys, this is a hands-on human event, not an automated computer event. Your packet has to go to the Board of Nursing. They have to look at your background check as well as what you submitted to them and say that you're cleared for testing. That goes back to Prometric, which is our testing agency, and then you can be scheduled for testing. This is not done by a computer. It's done by a live human. That means that holidays are going to affect this. Okay? Just like you don't like to work on holidays, yeah, the Board of Nursing doesn't either. We have the 4th of July coming up. So remember that the 4th of July is a holiday. And a lot of times with holidays, people take off the day before or the day after, and this can extend testing timelines a little bit. Just keep that in mind. Once they approve you for testing, it goes back to Prometric. They say, yes, this person is okay to test. Prometric then schedules your testing date. So there are a lot of moving parts to this process. We're going to go through each one individually. Question I get asked a lot is, but Miss Patty, I have a background check. I already work in healthcare. I've done a background check. This is not coming from me. This is coming from the Board of Nursing. If you go on to Florida's Board of Nursing, which is floridasnursing.gov, and their FAQ section, I pulled these are screenshots off of their frequently asked questions. They have it in 2 different places on their FAQs. They're very serious about this. A new background check is required for all new applications for the CNA exam. A new background check is required at the time of a new application for a CNA exam. So even though you may already have a background check somewhere for something, the Board of Nursing is very clear. They need a new background check. I know somebody is going to argue with me. I have no control over this. This is the Board of Nursing. Now, that being said, I will tell you that recently I did have somebody who did not go get a background check, who is working in healthcare, and they were approved for testing. Made sure to let me know about it. So whether you want to take that chance or not is up to you. Now, if you look on the back side of that sheet that we just handed out, it shows you the steps to register for a background check. Now, let me back up here real quick. This is not the only place that you can get a background check. You can get a background check in about a bazillion places. It must be a level 2 photo-enabled background check using a very specific code. You can go anywhere and get that as long as it's photo-enabled. Okay, level 2. I recommend this company because they seem to be the cheapest and you can get appointments usually the same day. So this is who we recommend. Doesn't mean you have to use them. But if you do decide to go through them, these are the steps to fill out their online registration. This uses the UPS store at Barclay and Spring Hill Drive. You can go other places and get it wherever is more convenient to you. If you do a walk-in, if you register online, it's one price. If you walk in and say, I don't have an appointment, and they register you, they charge you an extra $25. That's crazy. Just for them to type it into the computer. Register yourself. It's a lot cheaper. Now, you guys are in Citrus County. You'll need to just look up. Oh, you do? Okay. All right. Yeah, there's literally hundreds of background places all over the place, but you want to make sure you're getting one that is photo enabled level 2. That's the big thing. But also make sure that it's not like too terribly expensive. Oh, yeah. Anybody can go here. And they actually probably have one in Pasco County because when you get to the end, you get to choose your site. Just put in your zip code and they'll pull up one closer to you. Yeah. So they use UPS stores all over the country. So that's just the one here. We have other UPS stores. We have one at Mariner and Northcliffe. We have one at Public. Yeah, we've got a lot of UPS stores, but they aren't all on this network. I don't know. All I know is this one works. All right. About a year and a half ago, we had a whole class that went through the sheriff's department. They didn't test for like 8 or 10 months. It was a horrible. And I had told students before, because we'd had a problem with the sheriff's department before. And I told students, I wouldn't recommend the sheriff's department because they'll tell you they do it, but there's always a problem. Well, this whole class went through the sheriff's department because it was cheaper. It was only like $40 or $45. It was way cheaper. And every one of them had a problem. Every one of them. In fact, like half of them went and got paid for another background check just to get their application processed. It was horrible. And they all came back at me and I'm like, I don't know. I don't know. But that's why we started just recommending this one. There's never, ever a problem with this company. And they get the background checks submitted really quick. Now, here's the thing about a background check. When you go to the appointment, they're going to take your fingerprints, they're going to take a picture, and you're going to sign. They are not going to give you anything. You don't go home and wait for your background check to come. You cannot have access to your background check and send it somewhere because everybody has access to Photoshop now. I can take a horrible background and make it super clean for a couple bucks, right? So that's the problem. If there's any, and by the way, I don't do that. I was kidding there, okay? If there's any interference, it's called the chain of custody. If there's any interference between the company that runs the background check and the company that receives the background check, if there's any interruption in that, the background check is not considered valid. So you just go to the appointment and that's it. That's all you have to do. You're not going home and waiting for anything. Just go to the appointment. They send it where they need it to go. And they do that because we put a code in. And that code is on that paper. It's EDOH0380Z. Okay? You use that code and it tells them that's the filing cabinet you need that background check to go to. So this is the process. This is what happens. You go get the background check. They take fingerprints, picture, and signature, and they send you to a place. They send that information to a place called the clearinghouse. Think of it like a filing cabinet. They send your background check to that filing cabinet. Now, nobody else can access that filing cabinet except for medical. That's it. That is it. So if you have a concealed carry, it's not in that filing cabinet. If you work for a bank, it's not in that filing cabinet. This is medical only. That's why we have to use that code. Good? Make sense? All right. So once you do that and your background check is in there, 24 hours, you register for the test. So background check first, wait 24 hours, then do the test registration. Good? It's actually in the clearinghouse a little quicker than that, but we want that little bit of buffer. 24 hours is good. So this is the whole process. Whew, it looks complex. But let me explain this to you. Let me break this down to you. You go get your background check. It goes in the filing cabinet. You register for the test using the paperwork I gave you or online, either one. When you register for the test, Prometric goes to that filing cabinet and they pull your background check. If they go to that filing cabinet and they don't find it, your application dies. It just sits there. And it might be 3, 4, 5 weeks before they check again. So you definitely want to make sure your background check is in the filing cabinet before you register. Does that make sense? So you do your background check, you register for Prometric. Prometric grabs your background check and puts it with your application to create a package. Registration packet, background check, together, complete, and they take it over to the Board of Nursing and they hand it to the Board of Nursing. Now we got to wait on these people. Humans, not computers. And we wait. And we wait. And we wait. And this feels like it takes forever. In reality, it should only take about 7 to 10 days. We should get an email from Prometric that says you've been cleared for testing, usually in 7 to 10 days. Could take a little bit longer during peak periods. Remember, we're on the very end of a peak period right now. But you guys should be within the 7 to 10 day process. Everybody got the overview? All right, so let's get into test registration now. So I'm going to show you a lot of screenshots. I want you to mark the clock here. We are at 12:35 on the clock. When you'll have to go back and rewatch this. Fast forward to 12:35 on class 4. Okay, so just remember that. You might want to write it down on your sheet. 12:35, class 4. That's where you're going to go to get this information because you'll need to rewind to this at some point. If you go to Prometric's website, this is who does our testing, prometric.com/exam/nurseaid-FL. Whew, that's a big website. It'll bring you to this page. This is Prometric's student page. There's a ton of information on here, and it is complex. But this is the website you will want to go to. When you go onto this website, here, application process, these are all accordions, which means if you click on this plus it's going to open up and there's a ton of information inside. When you first go to the website, this is all you see. It doesn't look like there's much there. You have to open each accordion to get to the information inside. So when we click on that application process, this is what comes up. Right here, it has online application form and paper application. So there's two ways to register. You can register online, way faster, or you can register by paper. That's what we've handed out to you. We're going to fill that out in class together. The online application, exactly the same. So if we fill this out in class together, you can take it, use it as a template, and enter all that information online and get your testing date way sooner. Good? Good. Okay. So the paper application, if you click on that, it's going to bring this up, which is what I have passed out to you, or what Jake passed out to you. This is the application form. So we're going to go through this step by step. You probably want to grab a pen or a pencil, because we're going to fill some of this out together, not all of it. Some of it I'm going to send you home to do on your own. But some of it we will pass out together or fill out together. Right here, right in the middle, it's got a stop sign. That means stop. Don't go any further. Hold up. Please make sure that you have two forms of ID. One, government issued, non-expired with a picture. Driver's license, passport, state ID card. Government issued, non-expired. Had a student a couple months ago, came to me crying, went to take her test, didn't realize her driver's license had expired, and they did not let her test. They also don't give refunds. That was a $155 mistake. So make sure, take a minute to look. You need one government issued, non-expired photo ID, and then you need a secondary ID that has a signature. Debit or credit card works fine. Just make sure your signature is on the back and the name matches your photo ID. You can also use your social security number. You can use a passport, a military ID. A library card will work if you've got a signature line there. Now, once we know that we have two forms of ID and the names match, the next section here is ADA accommodations. If you need a seeing eye dog to take the test, you're going to have to fill out a packet, and your physician is going to have to, get involved. But this would be ADA accommodations. Down below that is your demographic information. We are not filling that out together in class. You can do that on your own. Okay, bottom of page 1, demographic. It's all about you, your name. Turn the page to 2, your address, your race, your email, your gender, and whether or not you have a high school diploma. I want to talk to you about a diploma real quick. You do not need a high school diploma if you are 18 or older. If you are under 18, do I have anybody under 18? No? Okay, good. If you are under 18, you do have to have a high school diploma to test. But if you are 18 or older, they don't care. You're going to check the box. This is just for data collection. Now, below that, we're going to get involved in. This is what we're going to fill out together in class. This section on the bottom of page 2. If you have a felony in your background, even if it was expunged, if you have a felony in your background, stay after class and talk to me. If you have no felonies in your background, for number 1, check no. You're going to skip A, B, C, D, and E. Do not put anything in those. Just for number 1, check no. Come down to number 2 and check no. So you should have no for number 1 and number 2. If you have a felony in your background, you need to see me after class. If you have no felonies, these 2 questions do not apply to you. Now, if we go to the next page, we have 3, 4, and 5, and I've got to explain to you what this is. If you have worked for a doctor who was involved in Medicaid or Medicare fraud at a provider level. And we do have several doctors in our county that were involved in Medicaid and Medicare fraud. If you worked for that doctor and you were involved in the Medicaid and Medicare fraud, you were taken to court and put on a list that says you cannot work in healthcare ever again. Have a great day. No, you're fine. Have a great day. You have been put on a list. Now, this is not a secret list. You would have had to have lawyers and go to court and be talked to. This is not secret. Nobody is on this list and goes, I didn't know. Okay. If that describes you, see me after class. If that does not describe you, for 3, 4, and 5, put no. Are we good? You guys seeing that this registration form is a little more complex than just name, address, and phone number? Okay, below that is disciplinary history. What this is asking is, were you a CNA in Florida or any other state? Or were you a medical professional of any kind in Florida or any other state and had action taken against your certification? So if you were an occupational therapist in Indiana, knocked around some old people, got your license suspended and moved to Florida, and you're trying to be a CNA here, they're going to say, hold up. Okay. So if you've never had a medical certification in Florida or any other state, your answers are no all the way down. Now let's go to the hardest question on the registration form, criminal history. There's 2 choices here, yes or no. If your answer is, well, maybe, then it's probably yes. Do not try to hide anything. If they find something and you check no, you will be ineligible for testing. So be honest here. No, and in fact, it actually says in here that reckless driving, driving while license suspended or revoked, driving under the influence, or driving while impaired are not minor traffic offenses for the purposes of this question. So that means if any of those apply, you have to declare it. But anything else is a minor traffic offense and doesn't need to be declared. Yeah, I drive a sports car. All right, the next question here is, have you ever had any records sealed? This is when you paid a lawyer $5,000 to make it all go away, and he promised nobody will ever find it. Yeah, we will. Yeah, we will. There is no such thing as hidden records or expunged records when it comes to healthcare. It's the one industry that we're allowed to look. And then down here, it's asking if you've ever been adjudicated delinquent. This is a juvie record, guys. You have a juvie record. All right, now going on to page 4. Everybody with me? Go home and fill this out. I cannot help you with this. Legally, I'm not allowed to give you any guidance on page 4. So let's go to page 5. 4 also has your social security number. Let's go to page 5. Now, page 5, I've already filled out part of it for you. You guys see that? I have checked off E3 Challenger. That is the route you will test under. Yes, I know you're sitting in a classroom. This is not a 120-hour program with clinicals. It does not count. So all of you are going to register under E3 Challenger. Over 80% of all people who take the CNA exam are challengers. You're in good company. It's the most common route of testing in Florida. That's because Florida is the only state that allows it. Down here, training information, I've got a big X through that, and I put an X through that because it tells us to only fill it out if we filled out E1 or E2 up here. We chose E3, doesn't apply to us. So let's go down here to test site information. You have to tell the testing center where you want to test. We have testing centers all over the state of Florida. If you want to test in Miami and then jump on a cruise ship to celebrate, go for it. If you want to test in Jacksonville because you got family up there and they want to celebrate your accomplishments, you can test in Jacksonville. You can test anywhere in the state of Florida. but you have to tell them which center you want to test at. So in the very back of this packet, the last 2 pages, right here, these are the testing centers in Florida. These are the testing centers in Florida. So, if you're on Prometric's website, this is what they give for testing centers. Okay, mine looks a little bit different. And that's because these are not arranged in any logical order at all. So what I did is I took that information and I put it into regions. So you know, Central Florida, these are your regions. If you're in South Florida, these are your testing centers. So I just reorganized them for you to make it a little bit easier. But Prometric has this same information on their site. So we are going to check off regional test site, and then we're going to tell them which test site we want to test at. Now for us, our closest testing site is right here, Agilus. I've got it highlighted for you. I highlighted the 3 that are in Tampa. Those are our 3 closest. But Agilus, it's not the bottom one, it's the one above the bottom one. That is our closest testing center. It's off of Waters Avenue down by the airport. The other 2 are on the other side of Tampa, like by USF, Busch Gardens area, and then over like past that. So you can choose where you want to test. I don't care where you test, but that's just our closest. Now, if you look on this form, you'll see at the very beginning is a code. It says CNA, TAMAIR. You're going to put that code in this box. Now, this is where online differs from paper a little bit. If you're doing the registration online, there's going to be a drop-down box, and it's all alphabetical. Just find the one that you want to test at, like Agilus. Just find that one. It's a drop-down box. Good? Questions? Below that are your exam fees. Now, exam fees are standardized, but you do have a couple of choices here. Do I have anybody that English that Spanish is your primary language? Anybody Spanish primary language? If Spanish is your primary language, you actually have the option to take the written test in Spanish. So Spanish is your primary language, you can choose that. But for all of you guys, English is going to be your only other option. Now, there is something you can do, though. If you have a reading disability or if English is not your first language, you can have the computer read the questions to you and the answer choices. It's called oral or audio. And it just, if you have like a wandering brain, sometimes this can help. If you want that, it's the second option here. So if you want the computer to read you the test question, it's the second option. Everybody else choose the first one. That's the plain Jane standard test. That's the one everybody chooses. If for some reason you are unsuccessful on the state exam, if you fail a part of the state exam, you only have to retake the part that you failed. So if you passed the written but failed the skills, you only have to retake skills. And you'll see those listed here. Okay, skills only or written only. You would only need those if you failed a part of the test. My students do not fail a part of the test. So you should not need this, but that's what these other options are. So our testing fees are going to be $155 because we are first-time testers. We're taking both sections on the same day. So our testing fee, it doesn't matter whether you're getting it read to you or not, is going to be $155. That is what you have to send with your registration form. So if you mail this packet in, the very last page is the payment page. So you would fill that out for your payment. If you do it online, there's actually a payment box that you're going to enter your credit card information in. Good? Good. All right, so go to page 6. Page 6, you have to check a box at the top that's yes or no. And that box is saying that you have received and read these 2 papers that are in your packet. This is the FDLE and the FBI privacy policy. Tells you how they're using your information to clear you for testing. So you need to check yes there that you've received it, because you did. It's in your packet. I gave it to you. Below that is your affidavit you need to read. You're going to sign and date. Do that on your own. Let's look down here at the bottom. It says, now this is going to be really important, guys. If you do not receive your emailed ATT letter, that's authorization to test, that says, hey, we got everything, you're cleared for testing, we sent it back to Prometric, we're waiting on a test date. If you do not receive that authorization to test within 10 to 14 business days, contact them. This is the timeline they are telling you that they should process your registration in. 10 to 14 business days, which is about 3 weeks of regular human time. Good? Good? Okay. Remember I said that we're running a little bit behind because it's season, right? Might take a few days more than this. Here's the problem. When you call up Prometric, you call Prometric. The person that answers the phone is a minimum wage employee that is paid to get you to hang up. That is their job. And they are going to tell you things like it can take up to 90 days to clear you for testing. What does your application say? 10 to 14. This is their contract with you. So when you call up Prometric and you say, hey, I haven't got my test date yet, and they say, yeah, it can take up to 90 days, you are going to say to them, my application says 10 to 14 days, and then I need to call. You are going to read this to them, and then you're going to ask for a supervisor, because the person that answered the phone has no idea what they're talking about. Their job is to get you to hang up. You don't want to hang up. You want to be the squeaky wheel, and you want to get a supervisor on the phone, because that's who will solve your problems for you, not the person that answered the phone. Make sense? I had 2 from my last class that called, and they were told, this is just the last class, guys. They called, and they were told it can take up to 90 days. Both of them called all upset. And I said, call back, get a supervisor. They did. Everything went through fine. Don't talk to the person that answers the phone. This is your contract right here, in their words, not ours. Okay? I can't overstate that. But notice they don't give you a phone number on here. They say call, contact us, but they don't give you the contact number. So if you go to Prometric's website, it's right there on the first page. It'll give you their phone number. Yeah. It also tells you here, if it's been more than 5 business days since you submitted an application and have not received confirmation, contact them. So the timeline here is we register, either paper or online. We register. Within 5 days, we should get an email back from them that says, hey, we got your registration. And it's going to give you a paper. And that paper, this is the other flyer. That paper looks like this. There's 3 areas on this paper that you want to pay attention to. And I've circled them for you. You want to make sure it says complete. That's that blue circle. You want to make sure that the gray circle is either blank or record found. If that says record not found, they don't have your background check. And your application has stopped. And then once you're approved for testing, down here, the purple one, it'll change from pending approval to So these are the 3 areas that you want to look at. Down here, it'll tell you which email is going to change which one of those. They're all color-coded for you. Easy peasy. Got it? Got it? Okay. All right. The online registration is largely the same as the paper registration, but there's a couple of key differences I want to talk to you about. We talked about this one. Your preferred test site, it just brings up a list of test sites. It doesn't give you addresses. So you need to go to the list of test sites to figure out which one you want to test at. Another difference is the payment screen. So in the payment screen, you're going to fill out your payment information, and then you have to check this little box right here, and it's super tiny. It says, I authorize. If you don't check that, the whole application stops, and you won't know why. Now, another problem is this. Now, just above this, you're going to see this little thing that says supporting documents. How are you going to send them by mail or by fax? If you have a criminal history, they're going to ask you for more information. They're saying, how are you going to send it? The problem is everybody has to fill out one of these. So check one. Check by mail. I don't care. You're probably not going to have to send anything anywhere, but you got to check one of these boxes. Otherwise, it won't submit. But this is our problem right here. If you hit save, which most of us want to do, it saves everything but your payment information. So if you hit save and then hit submit, which like everybody does, it submits your application without a payment and your application dies. And you'll sit there and wait and wait and wait and nothing comes because your application did not go through. So don't hit save, just hit submit. It automatically saves it when it submits it. Okay, good. Good. That's a big mistake that people make on test registration. All right. If you do hit save, go back up and fill out all of your payment information again. And make sure you check that little box that says I authorize. All right. So once we completed our test registration, we're going to wait usually a couple of days. We're going to get an email that says pending approval in that box right here, pending approval. And then we're going to wait about 7 to 10 days from that point, and we'll get our test date. This is the process. Board of Nursing reviews the application, approves it, sends it to Prometric. Prometric sends you an email. Hey, you were approved. Yay, you get an approved. But we're not done yet because Prometric then has to schedule your test with the testing center. Then they're going to send you an email that says this is your test date. So we get an email here and we get an email here. Okay, good. Open the attachments. Check your spam and promotions because these go to spam a lot. And then once you get your test date, go test and wow them. Okay. Homework over the weekend. You are going to do chapters 5 and 6. 5 is on dementia. Pay attention. You're going to have a lot of dementia patients in your career. 6 is on skills. We go over that in class. Read the paragraphs in between the skills. And if there's ever a discrepancy between what I tell you and what the book tells you, go by me. I'm the authority. Jake is passing out your review sheets. 2 minutes late. Sorry, guys. I'm getting closer. I am getting better. I'm dialing in that time. All right, those of you who joined us online, thank you so much for tuning in. We will see you on Monday for class 5. We're past the halfway point now. It's downhill from here. We know all of our principles. We're good. So thank you so much for joining us. Until next time, happy caregiving. Bye.